Of you. I, on behalf of the SAO Governing Council and Office Bearers, welcome you all in this webinar on step-by-step diagnosis and management of glaucoma. Before we start the webinar, I will seek permission from the President of SAO, SARC Academy of Ophthalmology, Professor OK Malla sir, to allow us to start the webinar. Malla sir. Sir, you're mute. Sir. Sir, you are mute.
I want to have 5 minutes. Is it all right, Rajesh?
Sir.
Yeah. I won't take more than 5 minutes or maybe less than that. What I want to say is I like to begin this webinar by welcoming you all. It has been a pleasure to see all of you, though virtually. Again, another thing, I hope you all are doing well and managing to keep away from the COVID, which has disturbed our lifestyle and our program also of the SARC Academy of Ophthalmology. And I want to congratulate and thank the organizers, mainly Raj, Azad, and Rajesh, Namrata, and their team for organizing this webinar for the first time in SARC Academy of Ophthalmology. And special thanks to Professor Nadeem, for organizing this special session this evening, on of glaucoma, and he has done plenty of work in glaucoma, and he has collected all the wonderful speakers from all these countries of the SARC, and thank you, Nadeem, for doing that. You have included all the countries of the region. And I must say the important topics I had asked Rajesh and also Raj joined me that we must pick up the important topics and concentrate on what the updates and highlight some of the new things on the subject, like today, glaucoma. That's what we're going to hear from the experts this evening. Like I said, Vision 2020 took care of, did a tremendous job, took care of the important causes of blindness, and we have been successfully eliminating them, namely cataract and trachoma, gerophthalmia, and low visions, and all those conditions are virtually now eliminated. And our problems now is going to be glaucoma, which we are going to deal with in greater detail, step by step, towards diagnosis and management. And then there will be some of the important retinal diseases, which we'll be dealing with maybe subsequently in our these webinars. Glaucoma is such an important subject. The other day I was listening to glaucoma and somebody very casually defined glaucoma as a disease of the optic nerve, full stop, and the most important #1 cause of irreversible blindness is glaucoma. And by the time the patient come to you of glaucoma, about 50% have already visual damage, So it's just such an important disease, and I'm sure we are going to deal with this disease this evening in greater detail, and they are going to throw some new developments in the diagnosis and management of the disease. I don't think I'll go further. Without going further, I would like to give the floor to our moderator to start the session. Thank you, Rajesh. Over to you.
Thank you. Rajesh. Thanks a lot for your blessings and permission to start the webinar. This concept of webinar under the SAO, under the aegis of SAO was conceptualized and thought of by Professor Rajvardhan Azad sir. And he's the person behind, all of us, collecting together and doing this academic exercise. So I'll request Azad sir to speak a few words on how he thought of it and, what all we should do in future webinars in order to make it successful. Azad sir.
Good evening, everyone. And it's nice to meet all of you. And as Nadeem said, that the COVID-19 has given us opportunity to meet virtually, and otherwise the physical meeting, for certain reasons, and for many other reasons, it's not possible for all of us to be on one floor. So this gives a very, very, very good platform for all of us to meet. Glaucoma, as a student and until now, glaucoma has been an enigma. And the definition of glaucoma, as I remember when I was a resident, that time that is a, is a condition where there is a pressure. There is a variation in the pressure. Earlier, we used to think that glaucoma is because of high pressure. And I'm, being very naive because in the midst of a glaucoma specialist, I'm making this statement. But nevertheless, more or less, it may be true. The glaucoma may be in high intraocular pressure and glaucoma may be in the low intraocular pressure. Glaucoma may be in the normal intraocular pressure. So glaucoma has been an enigma. And but for the recent researches and recent innovations like glaucoma valve and many other things which have come in the field of ophthalmology, that has revolutionized the treatment of glaucoma. As far as we are concerned, we are only concerned with, when we are doing retinal detachment surgery and putting the, the belt buckle, the pressure goes high, or maybe when we are injecting the silicone oil, then the pressure goes high. In all these situations, we need a glaucoma specialist. And, more or less, we all also have devised our own, treatment protocol for these conditions, which are related to, the retina, as Professor Malla said. The concept, as Rajesh said, I thought that in the plethora of these webinars, I thought it is better we, do few webinars, but that should be full of rich with the information, rich with the knowledge, and what could be the better way, to start with glaucoma, and that too from Nadeem. Nadeem has been a pioneer in this field in our region, and not only region, but internationally, he is well known for that. So I thought, let us start with Professor Nadeem, he'll organize on glaucoma. Then we have on retina, we have on other subjects, and we will be having every 3 months a webinar like this. We'll have a fewer webinars, but rich webinars, and webinars which will give useful information to all our participants, all our audience. And as the title of this webinar is Step-by-Step Glaucoma, I think this is very apt. I don't know. I think must be from Nadeem, Professor Nadeem only. So I think this is a very well conceptualized, and I congratulate Professor Nadeem for having the galaxy of speakers that we have today. And without going any further, I'll request Rajesh to carry on this session, and I'll be a silent audience until the end. Thank you very much for all of us, for all of you, to all of you, for having met virtually, and then we have been able to assemble this webinar. Thank you very much.
Thank you, sir, for your kind words. And we will begin the webinar, and we will keep having the opinions of our opinion leaders and the panelists. Nadeem, sir, you have to say something, or we shall start the speakers. You are mute.
I'd like Nadeem to give a what you call as a capsule of the whole this webinar, because he has prepared it. I want that he should give what all the speakers are saying. Just a small
Rajesh for the remarks. Yeah, thank you, Raj, for the compliments that you made about me. We're all together, and we are all brothers and sisters in this SARC region. You all know that this region is a little different from rest of the world. We have all the statistics, we have all the information mostly coming from the West, and they have their different format of diseases. Their glaucoma is very different from our glaucoma. So That's the reason that I have put up this topic of step-by-step diagnosis in glaucoma, because if anything is diagnosed properly, only then it can be treated properly. So the purpose of holding this seminar, the basic things for the diagnosis was to involve our residents, involve our young ophthalmologists, and also our accomplished ophthalmologists who are not glaucoma specialists, to have the understanding of the diagnosis before they move on towards the treatment of these patients. And SARC region in Asia holds majority of the population of the Asia. The India, Pakistan, Bangladesh, and Sudan, Nepal, and Maldives, Sri Lanka, and Afghanistan. All these countries, they compose major chunk of the Asia's population. And we have so many of the patients suffering from glaucoma that we ought to have ourselves very good understanding of the diagnosis, and our juniors should also have very good understanding of the diagnosis and management of glaucoma. So this was the main purpose of holding this topic, so that all of us come onto one page, and after discussion we bring onto consensus few things, few recommendations out of this webinar, so that our colleagues get benefit from this. So thank you very much. I think we are getting late now. We should start the presentations. Thank you, Rajesh, for accepting my request to be the moderator. You are the best person to hold this webinar as a moderator. Thank you, all of you, for being with us and sparing your valuable time for this webinar.
Thank you, sir, for the kind words. And we begin the webinar with the first speaker, and that is Professor Suman Thapa, who is the head of glaucoma, Nepal Glaucoma Eye Clinic, Tilganga Institute of Ophthalmology, Kathmandu, Nepal. And Professor Thapa will be discussing with us about glaucoma screening. So I'll request Professor Thapa to share his slides.
Good evening, everyone. Okay, so are you able to see my slides?
No, we cannot see your slides. Just go to share screen in the center. Have you opened the PowerPoint?
Yes, I've opened the PowerPoint.
Now you just go to the share screen in the Zoom screen.
Share screen, yes.
Click that.
I've got options of desktop, Microsoft PowerPoint.
And
open the presentation, sir.
Your presentation would be there, no? PPT.
Your PPT.
You will see an option with .ppt.
Just open and don't put it in slideshow, otherwise it will not come. Just
okay.
Open.
All
don't
right.
Put it
Just,
in slideshow.
I'm
Otherwise,
sorry about this. Okay, I'll now share screen.
Then it will be seen, the PPT.
Share.
You can see the slide. Click that.
Perfect. Now put it in share. Put it on the share screen. I mean, put it on the slideshow.
But these are not my slides.
They're not the slides.
This is Dr. Afzal's slide, I think.
This is one.
Sir will have to stop share. Now you share yours.
Okay, share screen. I'm sorry about this.
Then click the PPT.
Allow.
Click the PPT and then again click share on the right bottom. Share screen, then click the PPT and then there's a blue button on the right bottom, share. You have to click that also in the same screen.
Okay, so I'm pressing the share screen and then desktop. Share.
You have opened your PowerPoint, no?
I haven't opened it.
No, you have to open your PowerPoint first. You first open your PowerPoint.
I did that, but again,
No,
Open it.
open the PowerPoint, then come to this screen, then click share screen, and then you will go to your desktop where your PowerPoint is opened. You have to click that and then share, and then it will come.
Okay, now I am sharing.
You are seeing your PowerPoint?
I can
So,
Click that.
so actually your zoom is minimized. You can see a black box in the on your screen. Actually your zoom is minimized, I think.
Okay, no, everything is.
Yes, you can see the share screening option in the center.
Yeah, I press that.
Okay, click on that.
Share.
Okay, what option are you getting there?
I'm getting open system preferences.
Then any other options, sir?
Oh.
Is it a Mac?
Yeah, it's a Mac.
There should be no
Okay.
problem at all.
Okay. Can you excuse me for? Can the second speaker come so that I can take
You
some
know
help?
one thing, you email your presentation to
Yeah.
the admin. Admin, please coordinate kar lo. Then we can play it from
Yeah.
there. Huh?
Rajesh, can you go to the next speaker? Can you have the next speaker? But it doesn't look nice, because it won't be in order.
Yeah, but the
Isn't it?
next speaker who has not been able to join, I've been talking to her.
We are talking about step by step, and it's not going to be step by step. Let him
We'll
try.
start with Dr. Mayuri Khamar, and I'll request her to share her screen. She is the treasurer of the Glaucoma Society of India, and she'll be talking about gonioscopy and imaging of anterior segment for glaucoma diagnostics and management.
Just hold on.
Yeah.
Good evening, everybody. At the outset, I would like to thank organizers, SARC committee for giving me this opportunity to share some pearls on the gonioscopy and imaging in the anterior segment for the. Can you hear me? Rajesh, am I heard? Hello.
Perfect,
Yes,
perfect.
yes.
Carry on.
Absolutely
Okay,
fine.
carry on.
Okay. So gonioscopy is a fundamental part of the comprehensive examination, and it's done not only initially for all cases of glaucoma patients, glaucoma suspects, as well as the shallow anterior chamber, but it should be repeated periodically. Not only it gives the grading of the anterior chamber angle, but it is useful for the differential diagnosis of the secondary glaucoma. In childhood glaucoma, it helps us in the diagnosis as well as provides the prognosis. It is also done for the assessment of the change in the angle morphology after doing laser PI. And also one should know perfectly to do gonioscopy if you want to do laser trabeculoplasty. There are basically two methods of doing it: indirect gonioscopy and direct gonioscopy. Indirect gonioscopy again has two dimensions. It is a dynamic gonioscopy by doing indentation gonioscopy or manipulative gonioscopy. I will talk about that later on. Now, what are the informational goals when you do gonioscopy for primary glaucomas? Is this angle open or closed in its natural position? If the angle closure exists, is it oppositional or it is a synechial permanent closure? And if this angle is open, is this angle is occludable in the future? So these are our informational goals. And how do we interpret? Looking at the angle structures visible, it decides whether it is a narrowness or the openness of the angle. The iris configuration and pattern gives an occludability of the angle, as well as we can diagnose some of the syndromes. Abnormal features like pigments, blood vessels, everything exudates, this all will help in giving the secondary part of the glaucoma. Now, before starting the interpretation of the gonioscopic pictures, let me take you back to the basics. We know that the gonioscope has a mirror in it, and the mirror means whatever you see is exactly in the opposite part as shown in this figure. If the blood vessel is situated at 11 o'clock, in mirror you will see at 7 o'clock, and when you rotate clockwise, the relationship of the two structures will remain as it is. Now precisely let us diagnose angle structure from anterior to posterior. The first glistening band that you see here is the Schwalbe's line. Next to it is the anterior part of the non-pigmented meshwork, and the posterior half is pigmented trabecular meshwork. And then is the white line that you see here. A running white band is the scleral spur, and the gray zone that you see posterior to it is the ciliary body band or the angle recess. So one has to identify the structure while doing the gonioscopy first. And various grading systems are available depending upon the visibility from anterior to posterior, grade 1, 0 to 4 or 5. The speed classification is more useful compared to the other two. It is based on two variables, angle width, site of iris insertion, and the peripheral iris curvature, which could be steep as shown here, or the regular, or the queer as you will see in the pigmentary glaucoma. Now the angle width is the estimated angle between the line tangential to the trabecular meshwork and a line tangential to the surface of the iris. These are various pictures to show you the grading of the angle. 0 is where the iris is in direct contact with the cornea. Grade 2 where the trabecular meshwork partly is seen, and grade 3 where you can see this scleral spur here. And this is the ciliary body band visible. So this is a wide open grade 4 angle. Now suppose you have an angle, close angle or a 0 grade angle, then you can do various dynamic gonioscopy. Let me give you example. This is the manipulative gonioscopy. How you do it? Ask patient to look into the direction of mirror. Suppose mirror is superior, ask patient to look up and tilt the lens towards the center. So this will give you about the heel appearance, and you can see the opened angle there. This is the example, clinical example. Here nothing is seen, and when patient look up and you have tilted the lens, you can see the opening up of the angle. Another technique is indentation gonioscopy. Should be done with the help of 4 mirror, which has a smaller base curve and a flat base. So when you indent it on the center of the cornea, actually you raise the intraocular pressure in the antechamber, and subsequently opening up of the iridocorneal angle mechanically. If it is only oppositional closure, you can open it. If it is synechial closure, you cannot. So basically it enables the differentiation between the permanent and the temporary angle closure, and identify the platyoiris configuration or whether it is a phacomorphic induction of the angle closure. This is a classic example of closed angle. And on indentation, you can see the angle has opened up, and these are the patchy pigments. So it was a oppositional angle closure in between. This is typically to show you the double hump sign of the plateau iris configuration on indentation. It is nicely seen in this particular patient. Another technique in here is to identify the Schwalbe's line. Sometimes it is difficult to identify the trabecular meshwork in eyes that are either non-pigmented or excessively pigmented. So what we do, make a thin slit of light and hit it at the iridocorneal angle at the 10 to 15 degree angle. So that this is the apex and the anterior line of the corneal surface and posterior line, which meets at the Schwalbe's line, because subsequent structures are opaque structure. So there is a parallelopipe made, and the apex is stops at the Schwalbe's line. This is how you can identify where the Schwalbe's line is. This is a classic example of heavily pigmented meshwork, and this is the apex. Arrow is showing you where the Schwalbe's line is. Now, how to do the grading and recording of this angle structure that you have seen? Make a cross. This is how I am following. The posteriormost part that you see here, it is ciliary body. So I have noted down it as a ciliary body. How much is the grading of the pigment depending on the +1 or 2 that you have to put down. If any abnormal structure seen anywhere, you have to note down. And what is the configuration of the peripheral iris? And that is in this particular patient, it is a flat iris configuration. So that is been noted down. Now, while doing the gonioscopy, one has to record and code the following abnormal structures that you see. Let us go through one by one. Now, different grades of the pigmentation are seen in the anterior chamber angle, and this is the classic example of the very young infant whose angle is not showing a pigment at all. While here is the angle where there is a just visible pigmentation, inferior angle is shown here. And this particular photograph is showing you a patchy pigmentation and having mild variety. If it is grade 3 pigmentation, then you can see the sclerosphere, but not the trabecular meshwork structure. And grade 4 means intense, means none of the angle structures are visible. This is a classic case of pigment dispersion syndrome. You can see the Krukenberg spindle and the grade 3 pigmentation of the trabecular meshwork. Sclerosphere is still visible. This, and let me share you with you one example of post-operative cataract surgery case. Uneventful surgery was done. After 4th day, patient develops severely raised intraocular pressure, pain. But what you see here is the iris surface is studded with the black pigments. And then we decided to do the gonioscopy. And what you see is a patchy jet black pigments coming up and blocking the trabecular meshwork. Though it was an open angle, but it was the trabecular meshwork was blocked with the pigmented, this jet black pigment causing the rise in the intraocular pressure. Now, iris processes and the peripheral anterior synechiae has to be differentiated. The iris processes are lessee-code. It follows the depth of the anterior chamber angle. And sometimes if they are very thick, you can see the contraction on the light stimulus. While PAS, they are broad and tent up structures, very taut, and they may go up to the Schwalbe's line, while goniosynechiae, they ends before the Schwalbe's line. This is a classic example of creeping angle structure. You can see in between angle is open, but the patchy pigments and bizarre pattern is very much seen in this particular patient. The broad synechia, because of the inflammation or some other reasons other than primary angle closure, glaucoma has this type of pattern. This is a case where the iris is plugging the window of the trabeculectomy wound. And this is ice syndrome where the iris insertion is very, very anterior and the broad peripheral anterior synechia with iris atrophy is visible. Now, tropic glaucoma can have a variety of the findings, and the variable degree of the cleavage between the circular and longitudinal fibers of the ciliary muscle broad ciliary band is seen in this patient. And sometimes you can see the black ball sign as shown in the left hand side. And pseudoexfoliation may have a blotchy pigmentation. Pigmentation is more than normal, but you can see the PAX material in that particular area. The window can be seen blocked with the PAX material, which is a dandruff-like white fluffy matter. And Sampolisi's line is very commonly seen, can be sometimes misdiagnosed as the pigmentation of the meshwork. The normal vessel is rarity, but it is unilateral and a small band, kind of U-pin band, and never extends beyond the Schwalbe's line. While the abnormal vessels are multiple arborized vessel, fine vessels seen on the trabecular meshwork initially, and then they bend. So patient with the unilateral glaucoma recurrent attacks were there. So patient was sent to us for the evaluation, and while doing the gonioscopy, I found the abnormal pigmentation only one part of the meshwork. So while doing the documentation, we noticed that the pink hue came up and gradually the whole angle filled up with the blood. And it was a typical Amsler sign that you see with the inflammatory glaucoma. This was a case of Fuchs heterochromic iridocyclitis with the typical iris pattern. Any nevus or the tumor has to be recorded and to be monitored every year, and documentation is essential. This is a case with the uneven peripheral anterior chamber was sent to us. And then on the gonioscopy, the bump was seen in the angle, and then on UBM, we could identify this as a ciliary body cyst. After full dilatation, the cyst was visible to us. The silicone oil field dye, it is very easy to diagnose, but the gonioscopy can show you the various, how much is the angle closure with the silicone oil. The anterior chamber angle IOLs sometimes they do cause the glaucoma, and the one has to do gonioscopy where the haptic is and how much is the damage. The childhood glaucoma can have an anterior insertion of the iris, and the typical mesodermal dysgenesis pattern that you see here is visible in this particular. Sometimes you can see the membrane, and the meshwork is never nicely described in this. Prominent shawl base line doesn't need gonioscopy, but when you do gonioscopy, additional finding that you can see whether it is the iris processes which are coming up and attached to this shawl base line. It is the must that we learn this doing gonioscopy nicely, otherwise you cannot do SLT in this particular patient. The gonioscopy helps in posterior surgical assessment, and post laser iridectomy you should find out whether the angle has opened up or not. The failed filter, you have to do gonioscopy to find out whether the window is open or not. In this particular patient, you can see the blocking of the inner window. And the various procedures done, tip of the Ahmed glaucoma valve is seen here. That's why it is a functioning. Many times it is not visible to us simply on the slit lamp. And for prognostic purpose or for other eye who is having glaucoma or siblings having family history of glaucoma, one has to do gonioscopy and give them the guidance regarding. And never forget to see the disc through the central mirror. This gives you beautiful 3D. Very shortly, I will finish the anterior segment imaging, how it is relevant to us for the diagnosis. It allows greater sensitivity in the identifying the eyes with the appositional angle closure, because it can be done with the dark environment. And the consistency of the image is always better, and it is reproducible. It is a non-contact, non-skill dependent technique. Various techniques are available. I use ASOCT and UBM as and when required. And the anterior segment OCT gives excellent resolution, but the penetration is less. It cannot go beyond the iris surface, while the UBM has the ability to visualize structures posteriorly located. Depending upon the probe you use, you can penetrate more and more in this case. Now, first thing that you have to identify is identify the scleral spur, and then draw a line so that you know where the exactly trabecular meshwork is. So this is scleral spur, then angle recess. And with this technique, you can generate a lot of data like iris angle opening distance, angle recess area, or TISA. And it is also useful to know what is the mechanism of angle closure in this particular patient. It is more physiological assessment of the antechamber angle, whether the steep configuration of iris is causing the pupillary block, or the phacomorphic element is there, or the plateau iris configuration is there. The acute attack patients can be monitored, because we know that there is a choroidal effusion. It might precede or it may contribute to the anterior chamber angle acute attacks. And the posterior pushing mechanism, for example, spherophakic eye, can be identified by using the UBM or the ASOCT, and here there is no role of an iridectomy. And one, as we have shown the previous picture, the ciliary body cyst can be nicely seen by using the UBM, and the plateau iris configuration forward rotation is also nicely visible in this particular patient. The pigmentary glaucoma may have a reverse pupillary block as shown in this slide, and these are the patients who needs prophylactic laser iridectomy. And the post-traumatic glaucoma, gonioscopy though is a better option, but in early phases or if there is a hyphema, the technique ASOCT can give you identification of the cyclodialysis cleft or the angle recess. And in particularly pseudophakic glaucoma, one should use this technology. It gives you exact position of the IOL where it is. Here it is shown that part of the IOL is in the sulcus and rubbing the iris, and the haptic is also rubbing the ciliary body, causing the pigmentary glaucoma. It is also useful for the understanding the physiological variation of the ankle. Let me show you how. This is the eye showing you the open angle here. And now this is with the light open, small normal size pupil. Now see what happens on the closer of the light. There is a dilatation of the pupil and the iris is going out and closing the trabecular meshwork. So there is an induction of the appositional angle closure, and these patient needs the laser iridectomy. It also helps us in knowing the iris volume and what is the lens vault, and depending upon that, you can decide whether the lens removal in this patient is useful or not. In opaque media, one can assess the anterior chamber angle. You can identify whether the PI is patent or not, and you can evaluate the procedure that you have done. Like this is a patient just before the PI, and immediately after PI, you can see the flow of the aqueous into the anterior chamber through PI, and the deepening of the chamber is also seen. One can also do black functionality study in vivo by using this technique. And depending upon what is the layer or multiform reflectivity of the black wall pattern, subject conjunctival separation, you can find out that this is going to be a successful black all throughout. And this kind of hyperdensity, hyperreflective echoes is a sign of failing black. So in this patient, one has to release the releasable suture if you have, or the suture releases, and you can see the post-release immediately there is an elevation with the aqueous inside. You can monitor various options that you have used like collagen or the tube. But what is the shortcoming of the imaging? You can't see PAS, pigmentation, blood vessels, which is to be seen only by using the gonioscopy. Though it provides the structural assessment, the functional assessment is not possible. And indentation gonioscopy, which we do, is not possible by dynamic change, cannot be seen by using this technology. So use anterior segment imaging as a complement to the gonioscopy, not as a replacement. Thank you very much. Take care and stay safe.
Thank you, Dr. Mayuri, for a nice overview on how gonioscopy helps in diagnosis and management of glaucoma. And gonioscopy definitely is an art to learn and to master. And its interpretation in itself is not that simple. So it's really nice to show everything so well, so that definitely it's going to benefit the people attending this webinar. Thanks a lot. We can have the discussion later once we have the first 4 presentations, as we have. So we move on, and Professor Thapa will be sending an email to me, and he will be sending his PPT. So we can move on to Professor Nadeem, sir, and I'll request him to present on visual field interpretation. Professor Nadeem Hafiz Bhatt is the president of Ophthalmological Society of Pakistan and is an renowned glaucoma surgeon. Nadeem, sir. We can see, sir. Yeah, we can see your slides.
Thank you very much, Rajesh, and the whole galaxy of stars of SARC region present today in this webinar. And our chief, Professor O.K. Malla, is very well there, and you know, he supports all these activities, and we are very happy to be participating in these events so that we can contribute academically to our students and also to the ophthalmologists. My topic is visual field interpretation step by step. As you're all well aware that this is my hospital, and you're all well aware that glaucoma is a group of disorders characterized by typical glaucomatous optic neuropathy, which is clinically manifested by characteristic visual field changes with normal or raised IOP. So the importance of visual field changes will be highlighted in my presentation. You know that for making a diagnosis of glaucoma, we need to do the anterior segment examination, which has been very well highlighted by my predecessor in the form of anterior segment examination, gonioscopy, and anterior segment imaging. And that is very important for the diagnosis of not only the primary glaucomas, but also the secondary open angle and narrow angle glaucomas. The other important areas that we need to do is to see the optic disc and nerve fiber layer. And then we do some tests. And visual field is one of those tests, in addition to OCT that we will be talking about in the later talks. And visual field examination is actually the functional evaluation of glaucoma and its effects on the retinal nerve fiber layer. When we talk about psychophysical testing, in the terms of vision, it's the subjective testing of vision of an eye. But in glaucoma, perimetry is done to assess the peripheral vision of an eye. And when we say that peripheral vision, which is anything beyond the central fixation, which is 5 to 10 degrees. So 5 to 10 degrees is the central fixation, and out of there, we have a peripheral vision. When we say that we are doing perimetry, what do we actually mean by it? Perimetry is an attempt to assess visual threshold at a particular location in the visual field. And what is visual threshold? Visual threshold is the minimum level of light that can be perceived at a given location in the visual field. And this is also called as retinal sensitivity. The visual threshold varies from area to area in the visual field. It's highest in the fovea. It decreases towards the periphery. In the superior area, it is 60 degrees. In the nasal, on the nasal side, because of the nasal bridge, it is 60 degrees. Inferiorly, because of the malar bone, it is 75 degrees. And temporally, since there is nothing blocking the visual field, we have 100 degrees. So superiorly, the eyebrow blocks the visual field. It is 60. Nasal, because of the nasal bridge, it's 60. Inferiorly, because of the malar bone, 75. And temporally, nothing blocks it. So it is 100 degrees. And this is also called as hill of vision. And this is how it can be drawn on a paper or photographed in the sense to make it understandable to the students that fovea is at the peak. You can see that fovea is at the peak of this hill of vision. And as we move towards the periphery, gradually there is a fall of visual sensitivity in the retinal areas. There are basically two types of perimetries. One is the kinetic, which is also called as manual. And in this, visual stimulus of known size and intensity is brought from the periphery where it is not expected to be perceived. And at some point, it will move into an area where it will be perceived. And that point is called as visual threshold in that area. And Jerem screen, which we used to perform in our student days or in our training days, that's no more done nowadays. This is an example of kinetic perimetry. The other more recent and more important perimetry is the static automated perimetry. In this, we present a visual stimuli of varying sizes and intensities at fixed locations, and higher intensity stimuli are presented, and then gradually the intensity is lowered until the patient can no longer perceive the stimulus, and that is the visual threshold in that particular area. And Humphrey field analysis is an example of static threshold perimetry. The comparison between the kinetic and static: in kinetic perimetry, you can judge the length and breadth of the visual field effect, but you cannot judge the depth of the visual field effect. And in static perimetry, you can judge three of them: the length and breadth of the scotoma or the visual field loss, and also the depth. You can see the depth of scotoma can also be gauged with the help of static perimetry. The most important point to remember in this slide is that the earliest visual field detectable by automated achromatic static visual field testing corresponds to approximately 40% ganglion cell loss. What does that mean? It means that if you do the visual field analysis of a patient of glaucoma only after the damage has been done to 40% of the ganglion cells, the first visual field defect may be detectable. So this is the reason that we tried, and the technology tried to find out a solution for this problem, and we were able to design OCTs of the new generations in which there is early detection of glaucoma much earlier than the 40% damage of the ganglion cells. So OCT has become a preferable tool and a diagnostic facility for the early diagnosis of glaucoma, or it is, we can say, pre-perimetric glaucoma. So whenever we want to diagnose glaucoma at the pre-perimetric time, we have to use the OCT, because the visual field defects will come a little later. Whenever we want to diagnose the visual field defects, we have to understand few things in the anatomy of the retinal ganglion cells and their axons. And the important features are that the optic nerve and the axons of the ganglion cells, they make the retinal nerve fiber layer. There is a horizontal raphe line that intersects fovea and the optic nerve. And because of this horizontal raphe, the visual field defects respect the horizontal meridian, in contrast to neurological defects which respect the vertical meridian. Because we know that brain is divided into two halves, and all the the fibers, they either cross or they remain to the same side, and therefore there is a respect of the lesion in the vertical midline. Whereas in the glaucomatous visual field defects, there is a respect to the horizontal raphe and horizontal midline. The axons of the ganglion cells of nasal retina travel straight into the optic disc, whereas they make the temporal wedge defects. Whereas the axons of the ganglion cells, they are located temporally, they arc into the optic nerve, and they make the nasal step and arcuate scotoma. This is a list of the visual field defects in glaucoma, which can be seen at various stages of glaucoma. There can be generalized reduction in sensitivity, temporal wedge, nasal step, paracentral scotoma, arcuate scotoma, double arcuate scotoma, bearing of the blind spot, total loss of field except the central 5 to 10 degrees or temporal island, and finally and ultimately there is a total loss of field and total loss of vision. So these are the stepwise visual field defects which can be seen in the patients, and it all depends at what stage of the disease the patient is going to present to us. And when we do the visual field testing, we can find either one of these defects or a combination of these defects depending on the advancement of the disease. This is the horizontal raphe that I was talking about, which is present in the line of optic disc and the macula. And you can see the nasal fibers coming directly to the optic disc, whereas the temporal fibers, they arch around. They arch around the macular area. They arch like that, and they reach the optic nerve head. The optic nerve head, the size of optic nerve head is 1.5 millimeters, and this is the nature's miracle that in this 1.5 millimeter, 1.2 million fibers are getting together and passing and making this bundle of the optic nerve and going out of the orbit towards the brain. So we have a very compact optic nerve which has got 1.2 million fibers, which are representing various features of vision and visual field and color vision and other aspects of vision in those fibers. These are the few pictures of visual field defects and also the defect shown in the clinical examination. It's very important that your clinical examination and the defects that you see in the optic disc and in the retinal nerve fiber layer, they should correlate with the visual field pattern which is visible in the Humphrey field analysis or other machine or other tools used for the static threshold perimetry. So these few slides would show you the visual different types of this is the early superior nasal step defect, and you can see that the visual field also shows the same kind of visual field defect. So the clinical finding and the visual field defect should correlate between each other. Similarly, advanced superior nasal step defect, and you can see in the visual field there is also advanced superior nasal step defect, and there is gradually some enlargement of the blind spot also. And now here you can see there is the bearing of the blind spot, arcuate scotoma, and also the nasal step defect, and all these are joining together to show you. And you can see that the defect is respecting the horizontal meridian. It is not extending beyond the horizontal meridian because it's a glaucomatous visual field defect. Had it been the neurological defect, it would respect only the vertical meridian and not the horizontal meridian. And you can see the superior and inferior nasal step and superior and inferior arcuate defects, and they are joining together to make the circular type of scotoma. And there is a bearing of the blind spot here, and you can see both arcuates joining together at these, and these are separate bundle defects. They are not crossing over the horizontal line, They are just finishing at the horizontal line, although they are joining, they are ending at the horizontal line. So we can see a circular type of defect in the visual fields. And finally, the total loss of field of vision with preservation of central tunnel that you can see. Few important things there are clinical indications of perimetry. It is done either for the diagnosis in cases of raised intraocular pressure, suspicious optic disc changes, especially if the case is also has got myopia or a family history of glaucoma. And for management purpose, for the monitoring of glaucoma and follow-up, we do the OCTs, but also the visual fields to see the structure and the function. OCT would give you changes in the structure, and visual fields will give you the changes in the function of the retinal nerve fiber layer and optic disc. Now I'm going to highlight few of the reliability indices and then the global indices. The reliability indices, we have fixation losses. Here you can see fixation losses 2/19, which is reasonable within the normal limits. Then we have false positive errors, which are 3% in this case, which is also in the normal limits. 10% up to 10% of the total times that has been checked is taken as normal. And false negative errors, it's more than normal, it's 18%. The fixation losses mean that the patient is moving constantly in the eye and is not fixating to the target given. False positive error means that the patient is trigger happy and is pressing the button without even looking at the target. And false negative means that the patient is either fatigued or tired, or the defects are more than the expectation. So these are the reliability indices that we have to see before making any decision about the report. The other thing is these are the global indices, which are the mean deviation, pattern standard deviation, and mean deviation means that the mean of deviation from the age-matched normal population, and pattern standard deviation is that if you remove the intra-test variability factors like size of the pupil, refractive error, or lens changes, or cortical lens changes, or nuchal sclerosis, these factors are to be eliminated to find out the pattern standard deviation. So these are the global indices which help us in diagnosing the visual field defects more scientifically and more accurately. In conclusion, I would say that diagnosis of glaucoma requires high, if not the optimum, high index of suspicion, and patients of almost all levels of visual field defects and visual acuity can undergo visual field testing, and careful selection of patients for perimetry should be done. And monitoring of glaucoma can only be done by repeated optic disc evaluations and regular visual field examinations. As I've already mentioned, optic disc evaluation gives us the anatomical changes, and visual field examination give us the functional changes of the retinal nerve fiber layer. And with this, I thank you for your presence and attention. And as Rajesh said, that question and answer can be done at the end. I'm happy to answer any question whosoever asked that. Thank you very much.
Thank you, sir, for a very nice and comprehensive presentation on visual field assessment. And we can have question answers maybe after 4 talks, so that subsequent 4 talks can be done after that. We have Dr. Lalita from Sri Lanka. She is Dr. Lalita Sinarat, who is consultant ophthalmologist, teaching hospital, Karapitiya, Sri Lanka. And she'll be talking about IOP assessment and its role in glaucoma. So, Dr. Lalita, can you?
Rajesh?
Yeah, yes.
Rajesh, can you write down all the questions and then ask the speaker, rather than get each one of us speak up, because that will preserve some time. You understand? That's what I have noticed in webinars they are doing it. And you are the one who are going to put the question to the speaker, maybe in the end of the session, or like you said, after 4 presentation.
Yes, sir. The questions can be put in the chat box, which Rajesh can compile and ask everybody.
Yeah, that's what I mean. That's what they usually do. I have seen.
Right.
That will save time, I believe. Okay, thank you, Rajesh.
Yes, sir.
People can answer in the chat also.
Yeah, Dr. Lalita.
I can't hear. I think she's muted.
Dr. Lalita is muted and probably she's on phone.
Can you see my screen?
Yes.
Yeah. No, we can't see your slide. Can you share your slide, please?
Yeah. Can you hear me? Yes. Sorry
Yes,
for the delay of connection.
Yes.
Sorry. Thank you very much for just offering me this opportunity. Today, I am going to talk on IOP assessment and its role in glaucoma management.
Can you
Slide.
open your PowerPoint?
Sorry?
Slide.
You open your PowerPoint. You just open your PowerPoint and then share screen.
I think she's connected from phone.
Yeah, I have opened it. I have share the screen.
Yeah. No, but
I think the connection is on phone, so I think we'll have to get the slide.
I'm sharing.
or if you can, we'll have to get slides, I guess.
We'll have to get the slides on email.
Yeah.
Can Namrata help?
Yes, I will.
Can you see my PowerPoint?
I think one of the feedbacks that Rajesh we should note is that maybe for the next webinar, get all the presentations emailed to you.
We had started at 5 o'clock. We had started at 5 o'clock India time just to have a sort of a demo only, sir. But we will do it maybe a day.
Can you email your slides at this email which is there in the chat?
Next time you get the emails and then do it yourself.
That's it.
Meanwhile, I would like to invite Dr. Noman. Maybe he can start his presentation and we can do the rest. Dr. Noman is a senior consultant of. Sir? Can we go ahead, sir?
Yeah.
Maybe.
Sam.
Hello.
Yeah.
Hello.
Okay, Sam.
About optic disc evaluation key points.
Admin, can you put your email here for ma'am to email the slides to you?
We'll do it, ma'am. I'm in touch with her. I'll do it.
So, my slide is visible, sir?
Yes.
Am I audible?
Yeah, absolutely.
Yes.
Thank you. So, respected panelists and respected speakers, good evening to everybody. I'm really delighted to be here with you. And my topic is optic nerve head analysis, the points to be noted. So evaluation of the optic nerve head is the most important and key examination in the diagnosis of glaucoma. The optic nerve head is the distal portions of the optic nerve that is directly susceptible to elevated intraocular pressure. And what are the methods of evaluation? Through the direct visualization and through the imaging. So I am talking about the direct visualization of the optic disc assessment. We can do it with the direct ophthalmoscopy, indirect ophthalmoscopy, with like slit lamp biomicroscopy with 60 diopters, 78 diopters, 90 diopter condensing lenses. And my fellow colleagues will talk about the imaging system of disc evaluation like stereoscopic fundus photography, red field photography, confocal laser photography, and optical coherence tomography. So what are the important features to be noted when we see a disc? One is optic disc size and shape. Second one is optic curve size and shape, Coptics ratio, lamina cribrosa visibility, neuroretinal rim area and configuration, optic disc color, peripheral peripapillary region, optic disc vessels configuration, and peripapillary nerve fiber layer. And what about the optic disc size and shape? Normally, optic disc is an ellipse with a long axis vertical. Vertically, it is 5 to 10% larger than the horizontal diameter. And size varies with the populations even. African Asian have a larger disc than the Europeans. Men have a slightly larger disc than the women. And it is larger in myopia if it is more than 5 diopter myopia, and it is smaller in the hyperopia if it is less than 5 diopter hyperopia. more than 5 diopter, hyperipia. Then what about the optic cup size and shape? Normal shape is round to horizontal oval, and horizontal diameter is usually 7% larger than the vertical. So very interesting. The disc is vertically oval and cup is horizontally oval. And the Coptics ratio, we all know average Coptics ratio is on around 0.5, and less than 10% of normal population have a ratio of more than 0.5. And it is strongly correlated with the disc size. This is very important. And a neuroretinal rim, this is the portion of the outer side of the cup, between the outer side of the cup and the outer side of the disc. The average neuroretinal rim is 1.5 to 2 millimeter of square millimeter. Neural rim areas varies with the disc size. Larger discs have a larger rim areas. And 83% of the eyes follows the isn't rule. Inferior rim is greater than the superior, and nasal rim is greater than the temporal. Nerve fiber layer, radially oriented striations seen in the red-free photography. You can see the radially oriented nerve fibers that created from the optic disc. And I have already talked about the normal optic disc. What about the changes in the glaucoma? So the first change we have to notice is the vertical enlargement of the cup. The cup enlarged in glaucoma due to loss of retinal nerve fibers. Since early loss tends to occur in the superior and inferior poles. This causes the vertical enlargement of the cup. So ultimately the cup is enlarged vertically. And asymmetry of the cup size is very much important. In absence of congenital anomaly or significant anisometropia, left and right optic disc of normal individual resembles each other. Hence, any detectable difference more than 0.2 is unusual, and we have to make it a suspect. Alteration of the laminar cubosa. Normally, the round openings of the laminar cubosa are not visible because they're obscured by the nerve fibers. In glaucoma, the openings can be seen due to bearing of the laminar cubosa, the laminar dot sign. This is very important. And gradually, when the nerve fiber damage is more, the laminar pores will be enlarged, and the laminar dot sign is more visible. And it is a relatively non-specific sign. Oval-shaped slit-like is opposite to the round, and backward bowling of the lamina is visible in the 3D pictures. Here, the first one, you can see very starting of the laminar dot sign within the cup, and when the Coptics ratio is enlarged, there is a loss of neuroretinal rim, the laminar dot sign is visible. Neural rim loss. Generalized rim loss can be occurs, difficult to distinguish from the physiological cupping. Most common type of optic disc progression pattern in early glaucoma, and especially most common in the childhood glaucoma. So neural rim loss can be generalized and can be focal. So when it is a generalized rim loss, that there is a generalized enlargement of the curved disc ratio. So it is really very challenging to identify the early glaucoma in case of generalized rim loss. But it is very easy to diagnose a focal rim loss because it is a localized fiber loss. You can see there is a, in this picture, there is a gradual enlargement of the inferior cup, and that gradually touches the disc margin. And this is called the localized rim loss, localized fiber loss. If it is a less than 60 degree, this is called notching. If it is more than the 60 degree, then it is called the thinning. It can be unipolar, it can be bipolar. And it is a very diagnostic sign to diagnose a glaucoma, the thinning and notching. Neural rim configuration, what I have already mentioned, isn't rule. 83% cases, the isn't rule follows. But if there is any break of isn't rule, like inferior is greater than the superior normally, but in this case, the superior rim is greater than the inferior rim, it means there is some inferior rim loss. In that case, it is very much suspicious for the glaucoma, and we have to do for the further investigations like Humphrey visual field and optical coherence tomography. Pallor of the disc. Pallor is an important indicator of glaucomatous damage, but it is especially more important in the neurological damage. But it helps to diagnose a glaucomatous damage also, and can sometimes be difficult to separate from the cupping. As more lamina, white color become exposed, the area of pallor is increased. So it depends on the nerve fiber loss. The more laminar fibrosa is exposure, if there is exposure of the more laminar fibrosa, the more pallor will be visualized. Here you can see sometimes pallor will not coincide with the cupping. In the first picture, we can see there's a 0.5 Coptics ratio. Here, the pallor just coincide with the cupping. But here is the almost 0.7 cupping with inferior notching, but pallor is only almost 0.50% area. So sometimes you have to think that pallor may not coincide with the cupping. Bayoneting of the blood vessel. This is very diagnostic feature. In areas where the neural limb is absent or thin, a vessel may pass under the overhanging edge of the cup and make a sharp bend as it crosses the margin. This is called the bayoneting. And in this picture, we can see the inferior temporal loss of the neural rim in the glaucomatous optic atrophy creates a sharpened rim at the disc margin, a sharpened polar nasal edge along the cup margin, and the blood vessel become a bayoneting there. And this is a very important sign of the configuration of blood vessel in where the thinning or notching is occurred. So here is some of my patient picture where we can see a bayoneting sign of the blood vessel where the inferior notch is here. You can see a bayoneting here and also bayoneting here. So this is very much important. We have to follow. Sometimes there is a mistake that sometimes we follow the pallor of the cupping pallor, but we have to identify the bayoneting sign to identify the cup margin. Nasalization of vessels, it is not a very much indicative sign or non-specific, it is a non-specific sign. You know, the blood vessel remain nasally, but when the glaucomatous cup is progressed, the nasalization of blood vessel become more nasalized. Bearing of the blood vessel, bearing of the circumlinear blood vessel, this is also a non-specific sign. Vessel without supporting of the rim. When the rim loss occurs, the vessel become bared and it becomes a supportless. It just hanging. So it's the bearing of the blood vessel. It's another sign. Bearing of the blood vessel, what I have already told, it is more advanced cases, and we can tell it a vessel overpass because there is no rim base here. So the vessel become hanging in the media. Narrowing of the blood vessel, this is another new sign. The recently narrowing of the retinal blood vessel in the peripapillary region has been recognized in the chronic glaucoma. It is a non-specific for the glaucoma. This occurs in the areas of the greatest neural rim loss. Like you can see here is the neural rim loss, and you can see the narrowing of the blood vessel. And before even narrowing of the blood vessel indicate that there might be a possibility of the neural rim loss in that area. So this is also a very early sign, especially in the normal tissue glaucoma. Splinter hemorrhage, disc hemorrhage, peripapillary hemorrhage. This is another sign, and the risk factor for the glaucoma progression. Though it is a transient, but it is a pathogenesis is still undetermined, but repeated dilatation and constriction of the blood vessel in case of repeated fluctuation of the intraocular pressure is one of the probable cause of disc hemorrhage. This is one of my case where the you can see 0.9 cupping here, and in the inferior area there is some disc hemorrhage, And after, when I do the rate-free photography, you can see a nerve fiber layer loss here. So disc hemorrhage, especially in the normalization glaucoma, the progression, the glaucomatous nerve fiber layer damage progression can be diagnosed earlier with a disc hemorrhage. Peripapillary atrophy. This is also there are a lot of causes of peripapillary atrophy, especially in the myopia and glaucoma coincides each other. But you know, in the peripapillary atrophy, in case of glaucoma, is quite identical. Especially, we have to take care of the two zone of the beta zone and the alpha zone. In the beta zone, there is some RP loss, and you can the sclera is exposed here. But the alpha zone, there is some RP disturbance only, irregular pigmentation. For the glaucoma, the beta zone is very much important, as if the beta zone is enlarged, we have to think that the more nerve fiber loss and exposure of the sclera is more. So you can see some alpha zone and beta zones, and glaucomatous progression is more in the bit. You can see this is the beta zone. The more sclera is exposed here. Here is large area of sclera is exposed. So beta zone is very much important for the glaucoma. Nerve fiber loss. Different nerve fiber loss can be identified in the rate-free photography. It is a slit-like or group-like defects. It usually accompany with the notching. Wedge-shaped defect. It usually accompany with the thinning, and diffuse or generalized defect when there is any generalized Coptics Ratio is enlarged. So in that case, a generalized defect can be identified. So you can see this is a very small, tiny nerve fiber loss. This is called a slit loss. And you can see this is a wedge loss. And it is usually common in the bipolar notching. So what are the points to be noted? Optic nerve head analysis is the single most important examination for the glaucoma diagnosis. Only one examination technique. Even with a direct ophthalmoscope, we can suspect a case of glaucoma. Even you can, if you are in the desert, we don't have any instrument even, only one instrument is direct ophthalmoscope. We can have a confidence to diagnose even an advanced glaucoma. So optic nerve analysis is the single most important examination for the glaucoma diagnosis. There are other peripheral investigations available to aid in consolidation of diagnosis. First, note the disc size because it influenced other variables. Note various disc characteristics, what I have already included. Hope everybody has a healthy and non-glaucomatous disc. Thank you for your patient sharing. Thank you for giving me the opportunity. Thank you, everybody.
Thank you, Dr. Noman, for a nice overview on optic disc evaluation. We will have one more talk and then we can have a few questions and we'll proceed like that. So we are ready with Dr. Suman Thapa's presentation, and I request Professor Suman Thapa to do his presentation on glaucoma screening.
Good evening, everyone. It's a great pleasure for me to be able to be a part of this forum. So glaucoma screening has always been controversial. There are lots of views whether we should screen for glaucoma, whether we shouldn't screen for glaucoma. Can we please go to the first slide again? However, it is important, at least in my personal opinion, that we should screen for glaucoma. So the two photographs that you see over here, on the left is the Kathmandu city, which is a very urban city. And you can see the dense population. And at the same time, on the picture on your right is a picture of a remote area of Nepal where there are hardly any houses. and still habited. So this is up in the mountains and that's in the valley. So the screening strategies obviously have to be directed towards screening in large populations, as well as trying to screen for in places which is sparsely populated. Second screen, please. So glaucoma is the third major. So I'm going to present to you most of the data from Nepal because my research, my work is mainly is also research. So I'd like to talk to you about some of the evidence that I have on screening through research. So the RAP survey in 2020 said that, estimated that glaucoma is the third major cause of blindness following cataract and retinal diseases. And this is what is the ophthalmic infrastructure, the infrastructure of eye care in Nepal. We have doctors, ophthalmologists who are 350. We have about 22 eye hospitals, eye departments that are 20, community centers, more than 70. And that is the population to ophthalmologist ratio is about 0.09 per million. Next slide, please. And this is the geography of our country. Our country is very unique. We have the flat land, we have the middle hills, and then we have the mountains. And as you can see, in all of the areas where we have people residing, but the population is less in the mountains and more dense in the southern Tarai. And as you can also see, the road maps, most of the roads are in the southern part of the country, where it's geographically easier to build an infrastructure, but however in the mountains it's less. And the population growth is we have the younger people and the aged people are less. But however, this is data from 2014. But now, as with the aging population, the graphs have changed. Next slide, please. So first of all, to understand the burden of glaucoma and to understand screening, we have to understand what we are looking at. So there was a hospital-based study that was done in 2011, and we found that primary open-angle glaucoma was more or less equal to angle closure glaucoma. However, the Bhaktapur glaucoma study that was conducted in 2011, we found that primary open-angle glaucoma was 3 times more prevalent than angle closure glaucoma. And 80% of the angle closure patients were asymptomatic, and more than 90% had very poor awareness about the disease. Next slide, please. Bhaktapur glaucoma study. So after doing this population-based study, which is about, which had a population study of about 4,800 patients were enrolled in the study. So the main gist from the study, what came to my mind and what I learned was that screening for vision and intraocular pressure was not a very good idea, because most of the patients with POAG, 75% of the people had vision that was better than 612. And the intraocular pressure in approximately 85% of the people was within the normal range. However, when we looked at the optic disc, the visual changes, about 80% of them, of the patients, had visual field changes and optic disc changes. So we were thinking that maybe if we were to screen for glaucoma, we would screen only for visual fields and optic disc changes. And 96% were diagnosed at the time of examination and 90% were unaware. And even in angle closure disease, 70% were asymptomatic. Next slide, please. So screening for glaucoma. So why should we only talk about screening for glaucoma? We are talking about opportunistic screening. So if we club screening for glaucoma as a screening for posterior segment disease, which includes optic neuropathies and the retinal diseases, then we will be, then it would be a better reason for screening for glaucoma as well. Next slide, please. So we know that the early management glaucoma treatment study in the untreated arm showed that, for a normal field to go into blindness, it takes 75% or more in majority. So when we're looking at all these studies, they're telling us that really, do we really need to screen for early disease and moderate disease? Maybe not. Maybe what we have to really screen for are people with advanced disease and people who don't have disease, who are suspects. Because there have been conditions, there have been times in our clinic at Tilganga where patients have walked 3 days and traveled in a bus for 2 days and have arrived at us at our clinics, and they were suspected for glaucoma, and within a minute I would examine them and say that you don't have glaucoma. So they would have spent all those resources and to come to Kathmandu, and really they wouldn't have glaucoma, so they just have to go back. So that made me aware that it was as important to screen for people who are suspects but didn't have any disease. Next slide, please. So cost-effective screening. Screening is very expensive, as we know. If it's not a public health problem, then all the public health experts would say that there's no point screening for glaucoma. And also screening for glaucoma is expensive because we have these very expensive machines, and that are not portable, and that are desktop machines. And however, the way to go is by doing cost-effective screening, by using portable equipment and using teleophthalmology. And in the SAARC region, in our countries, what we have is that our primary level care is always given by ophthalmic technicians or ophthalmic assistants. And they are the first point of contact. And if we are to screen for visual field changes and optic disc changes, then we should use equipment that are portable and that are not expensive, that are inexpensive. And if there was a way where we would be able to send these photographs or send these changes to a tertiary level ophthalmologist, then we would be able to screen for glaucoma. And right there and then, we'd be able to say whether this patient would need to come seek further care. So next slide, please. Next slide, please. So this is just something that we did. Is there a slide before this? Did we miss a slide? Can we go to a slide before this, please? Okay, sorry. Okay, next slide, yeah. So this is what we did in 2014, where we experimented by using an iPad that had a visual field examination, and we used the picture camera. So we tried to combine these two techniques to be able to understand how sensitive and how specific were these tools when we in glaucoma screening. Next slide, please. So this is what you see over here. These are photographs that are compared between a standard tabletop topcon and an undilated picture camera, and you can easily tell that the quality of photographs are good, and with a trained eye, one would be able to say whether the patient has glaucoma or not. And on your right hand side, there is the printout from an iPad visual field. This is an app that we used, and then you have a Humphrey visual field for advanced glaucoma. So when we looked at all this, we said that yes, we are able to be able to say that we can screen for glaucoma through visual fields in advanced cases. These were comparable. Next slide, please. And these are some of the publications that we had in 2017, and we were comparing the two tests. They were in tandem, they were published. Next slide, please. And then we went further on and we said, okay, how can it be even more portable? How can it be even more easier? Something that we would have all the time in our with us. And so we looked at the iPhone. It's a smartphone, and we had a collaboration with Stanford University, and we looked into this as well. And this is what you see over here, is that you can do an indirect ophthalmoscopy, and with a 20 diopter lens. It can be mounted on an iPhone, and we are able to take photographs of the anterior as well as the posterior segment photographs. And this apparatus, it just costs about maybe $100 and not more than that, not including the phone and the 20 diopter lens. Next slide, please. So the photographs were taken. There was a cloud with all the information was uploaded in a cloud, and there was communication between the ophthalmic technician and the ophthalmologist. It just came up like a notification on a Facebook, and immediately we were able to communicate with our technicians, and they were able to communicate with their patients. Next slide, please. And so we started experimenting and see that how can we do this in our community center. So we divided this into phase 1. Next slide, please. And these were the 4 community centers that were connected to our center. So we had ophthalmic technicians. We handed the ophthalmic technicians with the smartphone and the Paxos scope. It's called as a Paxos scope. And we did a study. Next slide, please. And in this study, we compared the clinical examination of an ophthalmic technician, whether it was as good as the photograph. For example, the ophthalmic technician had to examine the patient, write the diagnosis, and decide whether to refer or not to refer. And then he was handed over the camera, and the photographs were taken and sent to the ophthalmologist. And we looked at the photographs and made a diagnosis, and we compared our diagnosis with their clinical examination. So we compared their clinical diagnosis with our diagnosis that was taken through photographs. Next slide, please. Yes, next slide again. And what we did find was that there were many cases that were missed, especially posterior segment diseases, based only on the clinical examination of the ophthalmic technician. And we did find that the camera did pick up cases that were missed by the ophthalmic technician. So we proved that it did have a role, and the apparatus did have a role in the community. Next slide, please. Yeah, so it was the feasibility, yes, it was easy to train and substantial rate of missed referrals, and it did have value in posterior segment diseases altogether. Next slide, please. And phase 2, we took it outside the community eye centers. So our community eye centers are at a very pivotal point in the district headquarters. But once you leave the district headquarters and when you go out to screen, then we don't have a slit lamp, and we don't have all the higher equipment. I mean, the most sophisticated equipments. So we took the Paxos with us. Next slide, please. And yeah, so we again we took photographs, and we were able to screen for vision, and we did the same experiment again. Next slide, please, where we compared the role of a flashlight in checking anterior segment diseases and a direct ophthalmoscope in making diagnosis against, next slide, please. Against, the same thing, that the camera taking anterior segment diseases and the Paxos scope taking posterior segment diseases. Next slide, please. And we again found that the findings were similar, in which again there were so many cases that went undiagnosed were diagnosed using our portable equipment. All right, next slide again, please. So we have reported this as well in 2019 and 2020, and we have been trying to say that this can be done, and if done correctly, we will be able to screen for glaucoma in a very opportunistic way. Next slide, please. And lately, what we are studying now is a virtual reality It's known as the Toronto Portable Perimeter. So we are doing a validation study for this and seeing if this can be compared with a standard Humphrey Humphrey visual field machine. Next slide, please. Yeah, so as you can see, these are the printouts over here. It's very comparable, and it looks not only just at a supra threshold testing, but it also does full threshold testing, and also it has apps. It has programs for looking into progression. So it is almost serving as a very well equipped visual field perimeter, portable perimeter. Next slide, please. And in phase 3, what we wish to do in 2020, but unfortunately, as we all have been affected by the pandemic, our research studies have halted, is trying to combine the smartphone teleophthalmology with the portal visual field evaluation. And we know that when we do this, we would be able to increase the sensitivity and the specificity of these equipment. And along with the clinical diagnosis and all of these three together, then we would be able to, along with the clinical examination and adding these two investigations, we would definitely be able to screen very well for glaucoma, no matter where we are, because patients are everywhere, not only in the urban cities, but also in the rural areas. So it is a challenge, especially in our countries, to be able to address the need of those living in the rural areas as well. Next slide, please. Thank you again, and wish you good health, and stay safe, and our greetings from all of us here in Nepal. Thank you very much.
Thank you, Professor Thapa, for a wonderful coverage of how glaucoma screening should be done, what are the things in pipeline, what you have planned in future, and that was wonderful, knowing all about it. We are in the middle of the webinar, and we have completed 4 talks, so maybe we can take up a few questions. There's one question for Professor Nadeem Bhatt, and that is, what is the ideal visual acuity at which we can perform perimetry?
You mean the lower and the upper limits? Because ideal is always the best visual acuity, best corrected visual acuity, what the patient gets. If the patient is 20/20 or 6/6, that is the best vision that he can perform the visual field testing. But even the vision as low as 3/60 or 6/60 can also perform the visual field test. It all depends what kind of target is being used, what is the size of the target, what is the intensity of the target, and there are features which are available in different machines, and those features can be modified to do the visual field testing even in very poor vision patients. So you can check the gross defects even if you can't do the fine testing. At least you will be able to do the gross testing, and then that gross testing can be repeated for that particular patient again for comparison. For example, if you've done the gross testing today and you do it after 3 months or 6 months, you can find out what is the progression of the visual field effects. So ideal is to have the best corrected vision first, and then use those spectacles for the patient, especially the near spectacles, which are to be used.
There's one more question for you, sir, that you very rightly, nicely you pointed out how visual field correlates with the optic disc changes and all that. So there's a query that whether it always correlates with the optic disc changes, or we do get surprises, or we do have some, disproportionate field loss or disproportionate optic disc changes.
If we are only dealing with a case of glaucoma and there are no other comorbidities, no damage to the visual field because of presence of exudates of diabetic retinopathy, changes in the central vision because of AMD or retinitis pigmentosa, peripheral sensitivity loss, then you will have the ideal the visual field changes, which will correlate. They should correlate with the optic disc changes. But if we have some other comorbidities, then there can be other defects which can mimic, like in retinitis pigmentosa, it can mimic the peripheral field loss. If we have drusen's in the macular area, they can cause some problem. If we have optic disc drusen or optic disc pit, they can also mimic some of the visual field defects of the glaucoma. But ideally speaking, if we are only dealing with a case of glaucoma, these visual field defects should correlate with the clinical examination of the optic disc. Similarly, when we see the OCT reports, they should also correlate with the anatomical changes that are happening in the optic disc. If they don't correlate with each other, then you have to check whether the reliability of the report of OCT or visual field is okay or not.
Okay, sir. There's a question for Dr. Mayuri, and this question is that dynamic gonio evaluation in terms of distance fixation with light on and distance viewing by patient in dark versus angles in dark and light while patient looks at near fixation done with UBM. What is your view about that kind of evaluation to know about the pathophysiology in a particular patient and adequacy of an intervention just as an evaluation of the various real life conditions and the way the interventions cover real life conditions?
What I showed was the intersegment OCT done in the dark as well as with the lights on the pupillary plane. And if there is a oppositional closure with the dilatation of the pupil, this is just like what is happening in the day-to-day life. The patient is in the room, there is a relatively dark area and the pupil size is not little dilated. Compared to that, when you go out in the dark, bright light, the pupil is constricted. So this is, and accommodation is not involved even with the UBM or the ASOCT. Patient is asked to look straight, that's it. Without doing any, there is no accommodation to that. UBM can also be done without the torchlight on and off. But this is a way to find out, instead of doing dilatation test that we used to do a lot of in the past. Now I am not doing it anymore. I take the advantage of the imaging that I have. That decides whether we should do prophylactic PI in this patient or not.
Okay. There's a question for Dr. Noman, and that is, are visible pulsations of any significance during optic disc examination?
Thank you. Sometimes almost 20% cases of in a normal disc, we can see the visible pulsation. But very interesting, in case of some hemangiomatous lesions in the orbit or in the behind the posterior pole of the orbit, and even in the Sturge-Weber syndrome, different acute hemangiomatous lesions, the pulsation will be more, especially in case of cavernous hemangioma, carotid cavernous fistula, and any other different cases where the intravascular pressure is fluctuating. In that cases, the pulsation will be more.
There's one more question for you, and that is, if the optic disc is showing more pallor and less of cupping, so what does it signify?
Actually, in case of, if we think of the glaucoma by seeing the disc, the most important thing is the cupping, not the pallor. And pallor may not coincide with the cupping. But if there is a gradual enlargement of the pallor, and this goes in favor of the optic neuropathy, neurological diseases. So pallor is one of the most important sign, but not the main sign for the progression for the glaucoma. But cupping is the most important. Thank you.
There's a question for Professor Suman Thapa, and that is, what is the role of artificial intelligence in doing glaucoma screening?
A very good question. I think to really tell you honestly that I wouldn't be able to answer that question very well. because my knowledge is limited in terms of how much research has been done. But yes, we have been involved in in an OCT screening for glaucoma, and artificial intelligence is going to be the way, because when we have a lot of data, when we have big data, and we're able to conclude on data from that to be able to screen, it will definitely have a role. But exactly how much there is at the moment and how that is going to be projected, I will not be able to tell you exactly.
Probably
But
time will
definitely
tell yet to know,
OCTs,
yes.
fundus photographs, these are the ways to go for screen.
So we move on to the next speaker, and we will have some more questions in the end. And the next speaker is Dr. Lalita Senarath, and she is a consultant ophthalmologist teaching Hospital Karapitia, Sri Lanka, and she'll be talking about IOP assessment and its role in glaucoma. So can we have the slides of Dr. Lalita, please? Admin?
Yes, sir. Just checking. Yeah.
We can't see the slides.
So, we can't see the slides, Admin.
Can't see the slides here.
Here.
Yes, ma'am. Just connecting. Just connecting.
Well, by the time it is connected, there is one more question that we can discuss, and that is for Professor Nadeem. And the question is that whether it's there. Anyways, we can have the question whether there is any specific visual field defect seen in normal tension glaucoma. What is the trend of visual field changes in normal tension glaucoma?
The visual field defects, normal tension glaucoma, you know that it is one type of open angle glaucoma. It's a type of glaucoma in which the pressure gradients are not as abnormal looking. They are abnormal for that particular eye, but from a standard parameters, they appear as normal. That is the reason it is called as normal tension glaucoma. But the glaucomatous changes in the visual fields as well as in the optic nerve are there. So only one parameter is missing, that the pressures appear as normal, but the visual field effects and the optic discharges are abnormal, and they mimic or they are like open angle glaucoma. So all the visual field changes that we see in open angle glaucoma, they will be there. But the other features like disc hemorrhage or progression, which is faster than the normal primary open angle glaucoma, that is there, and it may occur in relatively younger population. So these are the few things which are a little different from primary open angle glaucoma, which can be seen in the normal tension glaucoma. Their progression is faster, but their pattern is almost the same, just like open angle.
So do they have to be followed up more frequently because their pressures are
more frequently? You have to have high index of suspicion for them. You have to check their visual fields more frequently, and OCT for progression, OCT is not that helpful. Rather, visual fields are more helpful. You also do their neuroradiological studies to find out there are sometimes you see pituitary tumors, the early beginning of the pituitary tumors, and they mimic some kind of visual field effects early. The bitemporal hemianopia, or it starts looking like a nasal field effect. And if you get the MRI done of that patient, you find out that there is some tumor in the brain which is causing or mimicking the visual field defects. So all these patients should get the neuroradiological investigations in addition to other things.
Thank you, sir. So, Awa ma'am, you wanted to say something?
Me?
Yeah, I thought you wanted to say something.
No, I would like to use one question, Professor Nadim. What will be their target pressure in this normal tension glaucoma?
That's a very, very difficult question to answer because they already have a pressure like 10 or 12 or 13 or 14, and still they're showing progression in the changes and changes in the visual field. And you know, I have patients whose pressure is being maintained at the level of 6 or 7 after trabeculectomy, and their pressures are maintained at that level, and still they show little progression in their OCTs and visual field changes over the period of years. So their pressure initially was 14 and 13, and it has been brought down to 6 or 7. And only then we are able to control a little bit about the progression of their disease. So these are the patients who show very rapid changes, rapid damage to the optic nerve, and they have some vascular phenomena happening to them. And because of that, they show early changes in comparison to the primary open angle. So their pressures have to be brought to less than 10. Only then you will be able to maintain their visual fields to some extent.
Can I add to this, Nadeem?
Sorry?
Can I
Yes,
add
please.
to this what you said? Professor Eva Hussain, very nice question. The answer to this is there's a special clinic in Moorfields Eye Hospital that is called a normal tension glaucoma clinic. And there's a lady who heads it. I happened to attend that. I don't remember her name. And exactly what Nadeem said, they maintain people's pressure below 10 millimeters of mercury. And I was surprised and shocked to see that clinic then maintaining a pressure, because the definition of hypotony is that the pressure of less than 6 is hypotony. So they are maintaining patient's pressure between 6 and 10. And having said that, normal tension glaucoma is a medical disease. It's not a ocular disease, because you got to find a medical association like Raynaud's phenomena or migraine or things like that if you investigate the patient. Thank you.
Thank you, sir.
Can I add one line here, Dr.
Yeah.
Rajesh? There are normal tension glaucoma has many variables. One of them is only intraocular pressure that is been treated by us. But one has to look at the vascular phenomenon. So carotid Doppler study or the angiography, vertebral artery angiography and all this, and the apnea studies, that should also be added to your list of the investigation before you establish this as a purely a case of NTG. Because sometimes the compliance is also an issue. So there are so many points to be looked at before we say that it's only the intraocular pressure which is playing the role in this case.
Absolutely, ma'am. I mean, that's what Professor Imtiaz meant.
A lot of thing has been coming out. One more point I would like to say that if it is an advanced case of glaucoma, then 10-2 program is more preferred, and even the vision is less than 660 up to 3 meters. You can test that patient using the size 5 stimulus and the macula program. So that will add to your investigation for the monitoring of this patient.
Thank you. So we move on to the next speaker, and Dr. Lalita Sinarat will be talking about IOP assessment and its role in glaucoma.
Yeah, thank you very much, the organizing committee, for giving me opportunity, and sorry for my delay in connections. My apology. Today I am discussing the assessment and its role in glaucoma management. Can you move to the next slide? I have no financial disclosure. Next slide. Next slide, please. Why IOP is so important? Because every single millimeter counts for glaucoma progression. Next, please. IOP is the only modifiable risk factor in glaucoma. And the 1 millimeter reduction can be reduce the progression by 10%, and we can save sight years. Next, please. Eyes with IOP less than 18 millimeter mercury at every clinic visit over 6 years had almost nearly no progression. And while with intraocular pressure more than 18 millimeter mercury of the clinic visit shows drastically significant progression. Next slide, please. What maintain intraocular pressure? The intraocular pressure is maintained by the aqueous circulation within the eye. It is maintained by aqueous production and its drainage via the conventional and non-conventional, the US scleral pathway, and also directly correlate with the episcleral venous pressure. Next slide, please. What are the factors which is affecting the intraocular pressure? Next, please. The circadian, it's a circadian rhythm. There's a daily variation of the intraocular pressure. Usually the higher pressure have more diurnal variation. The diurnal variation is more than 6 millimeter, counts and very significant for glaucoma progression. Next, please. The lower corneal hysteresis also associated with greater risk of visual field progression and the glaucomatous optic neuropathy progression, because thinner cornea have a higher reading than we can expect. Next, please. Therefore, next please. The blood pressure. The blood pressure also have a direct effect on the intraocular pressure, but reduction of the systolic blood pressure has little impact on the intraocular pressure, and also has the atherosclerosis, the vascular effect also may cause progression of the glaucoma. Next, please. The Valsalva maneuver, the increased pressure within the lungs as well as in the abdomen, which cause increased episcleral venous pressure, also have a very dramatic effect on the glaucoma progression. Next, please. The lifestyle such as excessive exercise has drastically reduced the intraocular pressure for a short period. Therefore, doing exercise also have an effect on reducing the intraocular pressure. Next, please. And also the drinking large volume of water or fluid, rapidly drinking, can increase the intraocular pressure. Also, the alcohol and the marijuana can also decrease the intraocular pressure, but we can't practice because it's totally not ethical. Next slide, please. The intraocular pressure measurement is very important because there are several ways of intraocular pressure measurements, and there are indentation, applanation, combined indentation and applanation. There are rebound and also contour methods are there. Therefore, though there are several methods, the intraocular pressure measurement is a critical and has to be very accurate. Next slide, please. Based on the Imberg-Fix principle, the Goldman tonometry is the gold standard. It needed to flatten the area about 3.0 millimeter diameter in the cornea. But the Pascal is independent from the corneal thickness and biometrics and give a very good intraocular pressure reading. Also, the non-contact applanation tonometer like air puff is used for mass screening, and the rebound tonometer is coming up, has a very good correlation with the Goldman, which is very user-friendly, and it's very very good to use for screening purposes, as also it's very well user-friendly. Next slide, please. Errors in the tonometry can be due to the patient factor and observer factor and the instrumental factor. Next slide, please. The patient factor is due to low IOP reading. Artificially low IOP reading is due to the inadequate fluorescing within the eye. Therefore, it causes false low reading in the eye. And also, when there's an epithelial corneal edema, which gives a high degree of suspicion of high intraocular pressure, but it also can cause low reading falsely. And patients undergone refractive surgery has thinner cornea, also get false reading and the Pascal and dynamic contour tonometer are best tonometry for them. Next slide, please. The reading which are for artificially high due to thick fluorescent wires and pressure on the globe by the examiner's fingers, and if the patient is squeezing the eye, and if the patient is wearing a very tight collars or very tight ties. Therefore, we have to just relax the patient while sitting on the sit lamp and ask the patient to relax and breathe very slowly. And you should not press on the globe while you are opening the eye with your fingers, and should advise the patient to be rest on the sit lamp, chin rest. Next slide, please. If the patient have a distorted mire in distorted corneas like keratoconus, corneal scars, graft, then they have a distorted mires. Therefore, we have to take two readings, which the red mark has to be rotated in the axes, both axes, and give the average reading for those patients. Next slide, please. With the present COVID pandemic, infection control is mandatory because it can spread through the tear film. Therefore, clean the tonometer tip with isopropyl alcohol wipes or soak in a disinfectant. I hope all the participants and the panel also safe during this COVID state. Then we'll see what is the role of IOP in the management of glaucoma. Next slide, please. Next. Then we'll talk on the target intraocular pressure. The target intraocular pressure is the pressure range that is estimated to slow or hold the disease progression. Next, please. The target IOP range should be personalized and depend on the baseline intraocular pressure, stage of the disease, estimated progression rate, and the life expectancy. As we discussed in the earlier questions, we have to maintain the target IOP according to their baseline intraocular pressure. Next slide, please. The target IOP is a dynamic range. It has to be re-evaluated with time and varies from person to person. Next, please. The glaucoma, the patients with high-risk glaucoma, this actually, we don't have our guidelines and our data in our country. Thus, I took this from the APO guidelines, the risk categories of glaucoma progression. The patients with high risk of glaucoma progression, such as angle closure glaucoma, pseudo-exfoliating glaucoma, and the secondary glaucoma, and persisting high intraocular pressure, advanced and bilateral field loss, and also in young patients with advanced disease, they are the very serious patients. They need to control their intraocular pressure from their baseline about 40% reduction. Next slide, please. Therefore, it should be about 2 standard deviation below the population means. Next, please. Glaucoma with moderate 5-year risk of visual loss or a glaucoma suspect of high risk of visual loss. Those patients are primary angle closure with high intraocular pressure with peripheral anterior synechiae but may not have glaucomatous optic neuropathy. And also the patients with mild glaucomatous optic neuropathy with visual field loss or mild to moderate glaucomatous optic neuropathy with normal intraocular pressure, they need 30%. Next slide, please. They need 30% of intraocular pressure reduction from the baseline. Next, please. The glaucoma suspect of moderate risk of visual loss who are having ocular hypertension with other high-risk factors and patients with pseudo-exfoliation in one eye with established glaucoma need about, next please, need 20% of intraocular pressure reduction from the baseline of their present intraocular pressure. Next please. The glaucoma suspect with low risk of visual field progression or visual loss and have a low risk, and you have to monitor them very closely. But next, please. But they do not really need the treatment, and you have to weigh the treatment or whether you are following up the patient. Next, please. The glaucoma management is a risk factor reduction. Overall, you have to have a risk factor reduction by reducing the intraocular pressure, the IOP control, and you have to control the angle in angle closure glaucoma and treat the angle closure and treat the predisposing factors such as steroid use, uveitis, sleep apnea, instrument blowers, and many other factors may be physiological or pathological to minimize the raised intraocular pressure. Therefore, estimate the rate of retinal ganglion cell and the visual field progression by doing the software analysis throughout and regularly. Therefore, high rate of progression, we evaluate risk category and target IOP, and you can have a stable disease. Next, please. As I said, we don't have our national survey. We have initiated a national survey in our country on the glaucoma prevalence by conjunction with Ministry of Health, the Glaucoma Interest Group of the College of Ophthalmologists of Sri Lanka, and Vision 2020 programs. The data on national glaucoma prevalence and specific risk factors are essential to formulate and establish an intervention in the glaucoma management. Therefore, we have to rely on international glaucoma data and guidelines, which as we don't have this data. In Sri Lanka, we together initiated a national survey on glaucoma prevalence, and as the principal investigator, I hope we can shed the light of risk factors and the prevalence specific to the Sri Lanka, and we have a very specific management for our patients. Next, please. Yeah, thank you very much. This is my beautiful country, and in my city, I am working Galle, my lighthouse on a sunset. Thank you very much for giving me the opportunity for this lecture.
Thank you, Dr. Lalita, for a nice presentation on intraocular pressure and its role in glaucoma management. And next, we move on to our next speaker, and that is Professor P.S. Meher, who is consultant eye surgeon practicing at Aga Khan Hospital, Karachi, Pakistan. And he'll be talking about OCT interpretation and clinical scenarios. Admin, can we have the slides of Professor Meher, please?
Sir, good evening. Dr. Meher, you have sent a presentation where you need to give us access. So we are unable to access your file.
Okay. Meanwhile, we will move on to our next speaker, and that is Professor Afzal Bodla. And he is a founder, Bodla Eye Care, Multan, Pakistan, and he will be presenting on importance of MGCC in glaucoma diagnosis.
Rajesh, can I present myself, my slides?
Yes, it is visible, sir. Yeah, we can see.
Yeah, see what I have. Let me get you here.
We can see the presentation, sir. You can start. Go to slideshow, yeah.
You have to unmute yourself, sir. Unmute yourself.
Okay, I will present myself here.
Okay. Admin, please unmute.
Am I audible now?
Yeah.
Thanks. I'm thankful to the organizers of the SARC Academy of Ophthalmology and letting me talk on one of the very important topics, and that is the importance of the macular ganglion cell complex in glaucoma diagnosis. This is the ongoing study at Bodla Eye Care under the Pakistan Glaucoma Association, and the purpose of this study is to determine the glaucoma detection ability of ganglion cell complex in open-angle glaucoma, to compare the optic nerve head fiber layer thickness with the ganglion cell changes and to establish the criteria for the diagnosis of the pre-perimetric open-angle glaucoma. For the purpose, I have used Fourier domain optical coherence tomography, which is the RT view, with a software of 6.1 and phase 7. Next slide, please. The method to treat the patient selection criteria was the patient with a positive family history of open-angle glaucoma with a borderline intraocular pressure of 20 to 23 millimeter of mercury, having a minimum of 2 to 3 readings with the normal central corneal thickness, and on the clinical examination having evaluation of CD ratio of more than 3 and optic discolor and rim changes, and gonioscopic examination showing open angle of grade 3 and grade 4. Now this is a picture of the ganglion cell complex in which we have the nerve fiber layer, which have the axons of the retinal ganglion cells. Then we have the GCL, the ganglion cell layer, which has the cell bodies, and the inner plexiform layer, which have the dendrite. So that collectively makes the ganglion cell complex. And ganglion cell complex, that the macula is a flap-shaped structure without any large blood vessels at the posterior pole, and we can study the changes at the level of the macula, similarly as we can study the changes at the level of the optic nerve head. Although the studies at the level of the retinal optic disc level, they are going on, and that is a good marker of the glaucomatous damage. But with the recognition at the time, the measurement of the glaucomatous macula has made it very, very important. And the changes at the level of the macula, as well as the changes at the level of the optic nerve head, they are very beneficial for the diagnosis of the early cases of the glaucoma. We know that approximately 50% of the total retinal ganglion cell is synapse in the central 5 millimeter of the macula. There have been done different comparative studies, and they have shown that an objective structural assessment of the retinal nerve fiber layer thickness of optic nerve and macula by the imaging devices like the OCT, that is very useful. The Professor David Hung of the Casey Eye Institute, that he studied the different anatomical conditions, and he came to the conclusion that we can conclude it better when we are studying at different levels like the macula, the optic nerve head, that early versus the moderate and severe damages, they can be pointed out earlier. Similarly, by monitoring the rate of the thinning of the ganglion cell complex and nerve fiber layer, the glaucoma clinician can obtain objective measurement of the rate of the disease progression, and that can be used preferably in cases of pre-perimetric glaucoma. And similarly, when there are different studies was done by Professor David, it was found that OCT shows changes earlier as compared to the real field defects in the cases of the glaucoma suspects and cases of the pre-perimetric glaucoma. The progressive loss of the ganglion cell complex has been helpful in making the decisions to treat ocular hypertension in patients with the pre-perimetric glaucoma, and nowadays it is a known fact, and different studies had already proved it. If we go in detail, the average ganglion cell thickness is approximately 90 to 95 to 100 microns, and change of 5 or more microns is considered significant. And the glaucoma structural diagnostic index, now it is the criteria for the glaucoma diagnosis of the glaucoma. Now it has been studied the structural changes, they always precede the functional changes. By the time 20 to 30% of the nerve fiber layer has been damaged, the visual field changes, they begin, and the time difference between the nerve fiber layer damage and the visual field changes is approximately 3 to 5 years. So this is a major point now, that instead of the visual field defects on the macula, if we go on study the changes at the nerve fiber layer, they appear 3 to 4 years earlier and they are more apparent as compared to the visual field defect. The different studies as I am showing over here, and the different groups they studied the macula and the optic nerve head, they were the Wallerstein and colleagues. They studied the macular thickness and compared it with the optic nerve level. Then Ladder and colleagues performed a case control study evaluating the macular volume and its relationship with the macular volume with the optic nerve and Tan and colleagues had a cross-sectional study establishing some diagnostic accuracy of the ganglion cell complex. To summarize, we can say that if we are having a parallel study of the optic nerve head and the macula has its own importance, and its own importance because of the reason it has a flat surface, there are no blood vessels, and we can have it picturized easily as compared to the optic nerve head. The detail of the changes at the level of the macula, that is in two forms. They are in the form of the macular volume, macular FLV, that provides a quantitative measurement for the amount of the significant macular ganglion cell loss, while the global loss volume GLV that measures the average area of GCC loss over the entire GCC map. It indicates the diffused area. So changes, they are going to be in the form of FLV and in the form of the globus loss volume. Now here are the different cases. In case 1, that was a 21-year-old male. The intraocular pressure was a borderline, as I said, 22 to 23. CD ratio was 0.4, and the macular ganglion cell study shows the changes in the global loss volume. If you see the circumpapillary of the right eye, it is normal. Similarly, on the left eye, the circumpapillary nerve fiber layer thickness, that is normal. But if you see the macular area, there is a light global loss volume present. Similarly, on the left eye, we can see the left global loss present. So the optic nerve is normal, but the changes at the macula, they have started. In second case, again, the intraocular pressure was 20 to 23 millimeter mercury, open angle of grade 4, CD ratio being 0.6, and the macular ganglion cell analysis shows loss of global loss volume. Again, similar optic nerve was normal on the right eye. The left optic nerve was normal, while there was a global loss volume present in the right eye, and similarly, there was a global loss present in the left eye. This is a third case, again having intraocular pressure of 20/20 with a CD ratio of 0.6 and the macular ganglion showing changes normal optic nerve head of the right and left eye, while the focal loss volume shown on the right eye, and similarly the focal loss volume shown on the left eye. Again, case 4, having the global loss volume with the normal optic disc changes on the right and the normal optic disc changes on the left, with global loss volume present on the right eye and the global loss volume present on the left eye. And again, the case 5, having the similar changes, grade 4 open angle intraocular pressure of 21 to 22, and focal loss of changes, they were the borderline, normal optic disc on the right and left eye, with the similar type of changes with the focal loss volume on the right eye and the focal loss volume present on the left eye. Coming to a very interesting case that represents the GCC progression analysis. Now, this was a patient which was labeled as a pre-perimetric glaucoma and was put on the prostaglandin for the control of intraocular pressure. If you see, the intraocular pressure is 19 millimeter of mercury on the both eyes and grade 4 apenangle, while the macular ganglion cell analysis, when we go on to the optic disc, that is normal on the right eye, the left eye is normal. But if we see the changes on the macular ganglion cell normal, but on the left eye, there is a superior macular thinning with focal loss volume of 2.12% and global loss volume of 8.8%. Now, I continued with this patient, and after 5 months, despite of the controlled intraocular pressure, it was found the right macular ganglion cell that stays the normal, while there is increase in the focal loss volume of the left eye with 3.31% and the global loss volume of 9.4%. So that shows how the changes at the level of the macula, they progress despite of the control of intraocular pressure, and still in all these cases, there are no changes seen at the level of the optic nerve head. Now, this is the analysis of all these cases in which there is a focal loss or global loss volume, the optic nerve head is normal. Now, this is an ongoing study, and so far I have done more than 35 cases. Now, coming to the last patient, this is a 55-year-old male with an open angle glaucoma. And this was again on prostaglandin. Intraocular pressure was reduced to 16 millimeter of mercury. Now, if you see the right eye, there are disc changes in the inferior segment, while the left eye is normal. And if you see the macular ganglion cell, that shows the similar changes of the focal loss volume and the global loss volume as there were changes at the level of the optic nerve head. So on the same time, the similar changes, they are taking place at the optic disc head as well as at the macula. And this is the latest software in which we can have the changes. At the same time, we can measure the retinal nerve fiber layer thickness of the optic nerve head on the right and the left end, and we can have the changes at the level of the macula in the right and the left eye. Further, the macular ganglion cell complex analysis is divided into thickness of the superior GCC, inferior GCC, and average GCC. This is how we can know about the changes at the levels of the macula. My take-home message is the macular ganglion cell complex measurements are less variable than the circumperipheral retinal nerve fiber measurement, and that's the reason the macula is a flat structure at the posterior pole, and it is without the interference from the central retinal vessels, and it is without the interference from the peripapillary atrophy. Macular region having the maximum concentration of the retinal ganglion cell is the primary site undergoing the ganglion cell loss in glaucoma. The macular ganglion cell analysis shows early damage in form of the focal loss volume and global loss volume as compared with the changes at the level of the optic nerve head. And despite the stable IOP progression in focal loss volume and global loss volume, that indicates progression of glaucoma. Thank you very much.
Thank you, sir, for a very nice overview on the importance of macular ganglion cell layer assessment in cases of glaucoma. Can you unshare? Yeah. We move on to the next. Sir?
This is Captain Afzal Bodla talking from PK 737.
Yes, sir.
Sir.
ये ऐसे नहीं लग रहे जैसे किसी फ्लाइट के कैप्टन है.
That's right. Yeah.
We move on to the next.
Can you move on now? Yeah.
Yeah. Professor P.S. Meher, he will be talking on OCT and clinical scenarios. Professor Meher is a consultant eye surgeon practicing at Aga Khan Hospital, Karachi, Pakistan. And we have his slides. Sir. So, can you start?
Yeah, okay, just give me a second.
Yeah.
Please, yeah. Okay, good evening, everybody. Much SARC Academy of Ophthalmology for inviting me for this lecture. I'm going to stay on the role of retinal fiber layer analysis and the interpretation and diagnosis and management of glaucoma. And I'm going to show you also some clinical scenarios. My friend, Professor Afzal Bodla, already looked at the macular ganglion cells. Next slide, please. It's not moving from here, Rajesh. Okay.
No.
So early manifest glaucoma trial, United Kingdom, DTS, they all showed that the mean intraocular pressure in diagnosis is around 20 millimeters of mercury. And this is the reason that checking the intraocular pressure is the poor screening tool in diagnosis of glaucoma. And actually, this has just been resonated by also by Professor Sumantapa. Now, hypertension treatment study showed that the most patients who developed glaucoma from ocular hypertension showed the optic disc changes. So in general, the structural changes appear earlier than any change in the visual field. Now, we also understand that the visual field loss occurs after at least 35 to 40% of retinal ganglion cells are damaged. Next slide, please. Next slide, please. So if you're looking at the functional investigation in glaucoma, you have to do a visual fields, and this is a whole list of the field tests. You can do the standard automated perimetry, blue and yellow short wavelength, frequency doubling technique, and then the last one is the flicker defined form perimetry. Next, please. Next, please. Next slide. And for the structural or the anatomical assessment, we have got optic disc stereophotography, we have got confocal scanning laser ophthalmoscopy, and then there is a scanning laser polarimetry, and the latest technique is the optical coherence tomography, OCT, which has been fairly common over the last decade. Next slide, please. So what is OCT? OCT is the optical imaging technique with high resolution cross-sectional imaging of retina using the near infrared light. It uses the principle of low coherence interferometry using light echoes from the scanned structure to determine the thickness of the tissue. Next, please. So we have moved from time domain, which were a little bit slow, only allowing 400 scans per second, to the spectral domain, taking 20,000 to 40,000 scans per second. And now we have moved into the era of surf source, where we can have 100,000 scans per second. Next, please. Next slide. OCT detects the optic nerve head changes with RNFL thinning due to the loss of ganglion cells at macula. Now it compares the thickness of RNFL between the hemisphere of same eye and between the two eyes. It measures the thickness of rim, and it also measures the inner retinal layer thickness and ganglion cell complex at the macula. Next slide, please. Thickness of various parameters is then compared to the normative database. The normative database in most scanner is based on 300 to 400 patients with average age of 15 to 78 years. The database do not have patients with extreme refractive errors, young children, and people from different races. Segmentation algorithms in different scanner are mutually exclusive and they are not comparable. Therefore, long-term assessment needs to be with the same OCT scanner. Next slide, please. What's the drawback of OCT? Head tilt and microsaccades can result in the poor quality. Low signal scans due to media opacity underestimate the nerve fiber layer thickness, and there are artifacts due to incorrect segmentation of retina, which can occur into 5 to 10% cases. Next slide, please. Diseases like high myopia, epiretinal membrane, tilted disc confuse the software, and clinical interpretation errors also include failure to recognize compressive optic neuropathies because of pituitary tumors, ischemic optic neuropathies, retinal vein obstruction, as well as toxic optic neuropathies. Next slide, please. So Sanjay Asrani found that in his series of cases, there are 15.3 to almost 36% image-related artifacts in the glaucoma patients. So when you were measuring the glaucoma ganglion cells, IPL complex, this is prone to errors in eyes with macular pathology, such as age-related macular degeneration, diabetic retinopathy, and presence of epiretinal membrane. The other researcher has found that there are almost 40.4% patients who can have artifacts in the ganglion cell layer analysis. Next slide, please. So what should be our systemic approach for acquisition and interpretation of the OCT? We have to reduce room light in cases of undilated pupil, but a lot of people I've seen, technician, they will dilate your pupil. Ensure that the forehead of the patient is in constant touch with the headband. Remind patient to blink before the scan is taken. So because the dry eyes can be also one of the reasons that you can have errors in your scan. And confirm the name and age of the patients. Next slide, please. clinical signal strength has to be variable in different OC scanners and is defined as average intensity value of signal pixel in the ocular image. So these are the machines which are normally used in our country. Serious scan calls Zeiss. You have to have scan quality between 0 to 10. The best quality has to be equal or more than 7. So if you're using the RT view, the best quality has to be more than 40. And the Topcon machine, the best quality has to be more than 40 again. And then the Heidelberg machine. And here the quality has to be more than 20. So if your machine does not tell you exactly, you can always ask the manufacturer probably the best quality to get the best scan in your OCT machine. Next slide, please. Next slide. Okay, you have to check the refractive errors and if available, axial length of the patient's eyes, because this is helpful in pseudophakics and also in patients who have got refractive surgery done. The interpretation of the optic disc OCT, it compares the fundus image and thickness map, and which identifies the disc border and cup by OCT corresponding to the clinical estimation. Next slide, please. Recognize that the ocular disease can create segmentation errors. We already mentioned about the optic disc edema as well as the age-related macular degeneration, and the measurement from different brands of OCT machine cannot be directly compared. Next slide, please. So this is the patient who has presence of the epiretinal membrane, and when you take the OCT, or these OCT has been taken with the Heidelberg, and I'll show you how this photograph looks. Next slide, please. So you can see that's the epiretinal membrane in this patient. Next slide, please. This is the left eye of the patient, again showing the presence of epiretinal membrane. Next slide, please. Okay, so what epiretinal membrane does the software will recognize the ERM as the inner border of the retina. Therefore, it increases the thickness of the retina. That's the reason that you have got this thinning in one quadrant only. But these modern machines can remove the presence of the ERM and that can give you the different picture. So look at the next scan. Next slide, please. And that's the same patient. The machine has removed the presence of epiretinal membrane. Now you can see how much thinning is present in that patient's eye. Next slide, please. Next slide. Okay, now we want to look at the effect of improper scan alignment on the RNFL thickness also. Okay, so you look at the scan here, it's centered all around here, you know, from the center, measure out 300 to 350 microns surrounding the optic disc. Okay, we'll show you the next scan. Next slide, please. Now you see what we have done. Now this is the normal, this is the same patient, and we have just moved this scan slightly downwards, and it shows you that this patient has got a problem here. Now this is the way the improper segmentation is taking place. Next slide, please. Okay. And here, see, we have moved on this side, and you see the thinning on that particular quadrant. Next slide, please. And another one, you can see, and it shows you. We are looking at the same patient with the early slide I showed you, the center with no problem and no thinning of the RNFL. Next slide, please. Okay, so what I'm going to do is now I'm going to show you 4 cases in which I'm going to make you to realize that the RNF analysis can be helpful, but then not all the RNFL thinning is also glaucoma. So this is the first patient, 39-year-old male. He was referred to our glaucoma clinic for glaucoma evaluation. He was using retinoprost in both eyes. General health good, no comorbidities, no family glaucoma. His patient was 6'6". In both eyes, Gonio-scopy showed angle open on Schaeffer's classification, CCT. Right eye measured 537 macrons, left eye 536 macrons, and his intraocular pressure was 14 millimeters of mercury in his both eyes. Next, please. And this is his fundus photographs and the disc. In the next slide, I'm going to show you the magnified picture of the optic disc. Next slide, please. So we were pretty happy that this patient has got pretty thick rims, neuro rims, and they follow the isn't rule. So we're really not convinced that this patient, these discs doesn't fit in picture of glaucoma. Next slide, please. Next slide. This is the OCT of the right eye showing the RNFL analysis. Next slide, please. And this left eye of this patient, again normal with EFL. Next slide, please. This is the patient's visual field, right as well as left, all both normal. Next slide, please. We did not see any sign of glaucoma or glaucomatous damage in this patient. We advised the patient to discontinue all his anti-glaucoma medication. We rechecked his intraocular pressure after 4 weeks and his IOP after 1 month, 13 millimeters of mercury in both eyes. This was the mean at 9 a.m. and 4 p.m. And this patient maintained normal intraocular pressure over the last few years. And we just look at him every 6 months. And so that's the way the OCT has helped us to show the RNFL changes. Next slide, please. This is my second patient. This is a 40-year-old lady. She complained of painful decrease in her vision in the left eye. Her best corrected visual acuity was right eye 6.6 unaided, and it was 6.9 with some variation. Her intraocular pressure was 14 millimeters of mercury. Then we checked it in the clinic. Gonoscopy showed open angles. Again, we looked at these corneal thickness, 486 microns in the right eye and 492 microns in the left eye. So we faced this lady and we looked at her pressure in the morning and showed 12 and 14 millimeters of mercury. This was at 10 a.m. And then again, at 3 p.m., we saw a change at 18 millimeters of mercury. And at 5 p.m., this intraocular pressure went up to 23 millimeters of mercury. Next slide, please. This is the patient's optic disc. Next slide, please. So you see the right disc and the left disc. And what you see in the left disc is presence of the splinter hemorrhages. Next slide, please. This is the RNF analysis of patient's right eye. Next slide, please. And that's the left eye where you saw the splinter hemorrhage, thinning in the superior quadrant. Next slide, please. Next slide. And that's the patient's right and left Humphreys field, which are both normal. Next slide, please. So we thought this patient was having early primary open-angle glaucoma. Actually, we started the patient on treatment. Now, what is the significance of a splinter hemorrhage? Now, these are classically associated with presence of normal tension glaucoma, but they are also described in primary open angle as well as primary angle cruciate glaucoma. And they indicate the glaucoma progression and require enhancement of glaucoma treatment. And they usually precede neuroretinal rim changes and visual field defects. Next slide, please. Now, this is my third patient. This is a 43 years old lady, complained of decreased vision in her both eyes for 1 year. She was diagnosed as glaucoma, and she was using combination of dorzolamide and timolol and latanoprost, and she was referred to our glaucoma clinic for further evaluation. When we looked at her general health was normal, no family history of glaucoma. Vision was 6/6 in both eyes with small correction. Angles were open on gonioscopy. Her central corneal thickness was 500 macrons in the right eye, 495 macrons in the left eye. And the pressure was 13 millimeters of mercury in her both eyes throughout the day. Next, please. This is patient's optic disc. Now, they're a little bit different in the color, but this is because of the way we expose the patient with the camera. Next slide, please. So if you look at it, the rim thickness looked reasonably good in both of the eyes. Next slide, please. That's the OCT of the right eye. Next slide, please. And that's the OCT of the left eye. Can I have the next slide, please? So that's visual fields and shows you the temporal disc on the either side. So we were not happy to fit it in glaucoma. So we requested MRI of this patient. Next slide, please. And that's the MRI of the patient. And you can see the patient was detected having pituitary tumor. Next, please. So the patient had pituitary macroadenoma and he was referred for further neurosurgical as well as endocrine opinion. Next slide, please. Now, this is a very interesting patient. This is a 27-year-old, actually medical doctor who was working in my university hospital. Now, he complained of that he's not able to appreciate the inferior area of his visual field in the left eye for the last 6 years. So he went to see a neurophysician where he was doing his rotation. His MRI was done, no space occupying lesion was detected, and he had his both visual fields done. Next slide, please. So you will see the right eye looked absolutely normal, but on the left side, he has got inferior arcuate scotoma. Next slide, please. This patient was referred to an ophthalmologist for his opinion. His OCTs were done. Next slide, please. This is the right eye, did not show any changes in the RNFL layer. Next slide, please. And that's the way. There's a quite extensive thinning on the left side. Next slide, please. So patient was diagnosed as glaucoma and he was started on combination of dorzolamide and timolol therapy. Next slide, please. Now at this stage, he was referred to us for his glaucoma evaluation. His base criteria vision was 6/6 with -2, and in left eye, the same. His intraocular pressure was 16 millimeters of mercury in both eyes. Again, central corneal thickness looks fine and his angles are wide open. Next slide, please. And that's the way his optic disc looked. Okay. So I'm not sure what neurologist and other ophthalmologists are looking at. Next slide, please. That's the right disc normal. And I'm sure majority of you can diagnose that this patient has got optic disc drusen, which can give you the changes in the visual field. And this is the reason that two doctors who saw him, they misinterpreted it as because of the RNFL thinning also on the OCT that this patient is suffering from glaucoma. Next slide, please. And this is the autofluorescence of the left eye. You can see the calcified bodies present on the optic disc surface on the left side. Next slide, please. And actually we got his MRI back when it was first seen. They were looking at the space occupying lesion, and you can see the calcified present on the disc on the MRI. This was the old MRI, which was first time done by the neurologist. Next slide, please. So this is the optic drusen, the left eye, and patient's anti-glaucoma drops were discontinued. So what I'm trying to tell you is that the RNFL thinning helps you when you do the OCT, but you have to also understand that this thinning is not always because of the glaucoma. Next slide, please. Detection of glaucoma and its progression remains one of the most challenging aspects in the management of the disease. Now, OCD has improved our diagnostic capabilities and allows for early detection and progression. We clinicians should be aware of various artifacts which can be related to acquisition of scans by our technician, disease itself, as well as also related to the scanner. Next slide, please. And I thank you for listening to me.
Thank you, sir, for a very nice and extensive coverage on OCT and its interpretation and its help in diagnosing and treating glaucoma cases. We move on to the last speaker, and we have Professor Syed Imtiaz Ali, who is the head of the Department of Ophthalmology at Al Nafis Medical College and Hospital, Pakistan. And he'll be talking about what's new in glaucoma. Admin, can we have his slides, please? Sir, can you unmute? Yeah.
Yes. Can you hear me?
Yes, sir. Yes, sir.
Right, right. So after all the basics that we have heard, now I'll take you a little into the future. That's what's going to happen to glaucoma diagnosis and management in future. So can I have the next slide, please? Future of glaucoma therapy is focusing on increase in specificity for the individual patient, the type of glaucoma, underlying mechanism, genetic makeups, comorbid conditions, rate of progression, and the object is maintaining functional vision and improving patient outcome remains the goal of all the glaucoma therapeutics, medical or surgical. Next slide, please. Now, there are two kinds of advances that we can discuss. One is medical treatment, and the second is the surgical treatment. Next slide, please. Now, in the last 10 years, there have been advances in medical treatment, and the drugs which are coming onto the scene are the following. They are called the ROCK and NET inhibitors. They can be classified into Rho kinase or the ROCK inhibitors, the adenosine receptor agonists, and modified prostaglandin analogs. Next, please. These Rho kinase inhibitors are serine and threonine kinase that regulate contraction of the smooth muscle vascular endothelium and other cell types. And ripasudyl hydrochloride is one of them. Second is nitarsudil, which is available now in the form of drops alone and with latanoprost, and the combination is called the rocklatan. It lowers the IOP by an average of 1.8 millimeters more than the latanoprost monotherapy and 2.7 millimeters more than Ropressa, which is called the nitarsudil. And FDA has recently approved rocklatan, the combination for open-angle glaucoma and ocular hypertension. Next slide, please. Now, how do they work? The Rho kinase inhibitors lower the IOP by targeting the trabecular meshwork outflow pathway to increase aqueous humor outflow, and this includes ripasudyl and nitarsudil. Next, please. There's another drug which is called Vyzulta. It has been recently approved by the FDA as a glaucoma medication, and it has got a dual action. It was approved in 2017. This is called latanoprostin bunod, 0 to 4%, and it acts in two distinct ways. It improves the UV scleral outflow, and it also releases a molecule of nitrous oxide. On the other hand, it appears to use all outway pathways using as a prostaglandin analog, and it is called a prostaglandin plus. Next slide, please. Now, we can give the drugs as drops, but now we have delivery devices available very soon into the market. Next, please. They can be sustained release delivery devices, and they can be external devices that deliver the glaucoma drugs. You can see in the picture that this plug is being inserted under the eyelid, and which will remain there for a few months. Next, please. Now, we already have available drug delivery implants for glaucoma management. For patients who with poor adherence to topical drugs, delivery implants that provide sustained IUP management hold promise and are currently in development. The bimatoprost ring has been developed by Allergan, bimatoprost sustained release, biodegradable intracameral implant, and there is one iDose is another sustained release travoprost intraocular implant. The topical ophthalmic drug delivery has also been developed, and it is inserted under the eyelid and is concealed there. Next, please. So the new drug delivery devices are oval or ring-shaped device through bimatoprost, rod-shaped device by travoprost, and punctum plugs by the manufacturers of latanoprost. Next slide, please. Now, this is a subconjunctival latanoprost implant, shows sustained IOP reduction through 3 months, and it is proving very successful. Next, please. You can insert it under the conjunctiva. And this is the trade name of bimatoprost implant, 10 microgram for intracameral administration. And I'll show you a very small video. Next, please. It should start automatically. This is the device on which you load the implant, and you inject it into the anterior chamber, anterior to the iris, remove this safety plug and just insert it there. It can be delivered into the anterior chamber, and then when the patient is put in standing position, it goes and you can see it on gonioscopy in the angle. It can stay there for 3 months and deliver bimatoprost. Next, please. So a new drug delivery system utilizing nanoparticles embedded into a contact lens, which releases timolol from the contact lens when it comes into contact with the tear film lysozyme. This is also being developed, and this will be in the nanoparticles introduced into the eye. Next, please. Now, the next landmark thing is called the MIGS on the surgical side now. Minimally invasive glaucoma surgery. There are the different the devices that you can see can be inserted through the sclera or through a very, very small incision. Next slide, please. Now, what is the definition of MIGS? The MIGS should have these 5 characteristics: high safety profile, minimal disruption of normal anatomy, internal approach, efficacy, ease of use for patients and physician. And they lower the IUP by 20%, but they're not as good as the traditional surgery. Next, please. So minimally invasive surgery fills it's a low-risk treatment option with topical medication. Patients with mild or moderate disease or non-compliant and poorly controlled drops for whom the risk of more invasive surgery may outweigh the benefits of the treatment. Next slide, please. MIGS is ab interno approach for patients who have mild to moderate disease, and they cause minimal trauma to the eye, very little or no scleral dissection, minimal or no conjunctival manipulation, may allow surgical intervention early in the course of the disease. These are the advantages. Next, please. Now, what are the indications of MIG? Mild to moderate primary open-angle glaucoma, pigmentary, and PXF. Age should be above 18. Cataract with glaucoma is an indication. Uncontrolled with maximum medications, and patients who are intolerant to medications like brimonidine. Next, please. What are the contraindications? Primary angle closure glaucoma, secondary advanced glaucoma, previous glaucoma surgery, severely uncontrolled intraocular pressure, monocular patients, and previous refractive procedures. Next, please. So what are these are the different devices on the diagram. They are put in different locations. You can put them in Schellen's canal, trabectome, eye stent, and hydrus. If you want to drain them in the suprachoroidal space, you can use CPAS, iTent supra. And if you want them in subconjunctival space, XGen, gel, and microshunt can be used. Next, please. What are the contraindications for MIGS? Patients with fragile nerves, severe corneal opacity, synechiae, uveitis, chronic angle closure, and neovascularization. Next, please. So this is, can you play the video? No? Can we play the video? Can we go back and not? Yes. No, it's not playing. Okay, can we go to the next? Now, the next horizon that I want to tell you is called gene therapy. The goal of gene therapy is to reprogram the target cells to up or down regulate a biochemical physiological process by up or down regulating production of a specific substance within specific cells. The gene therapy can be viral gene therapy and it can be non-viral gene therapy. Next, please. A new study by University of Bristol has glaucoma could be successfully treated with a single injection using gene therapy, which would improve treatment options, effectiveness, and quality of life for many patients. The treatment targeted the ciliary body using the latest gene editing technology called CRISPR. A gene called aquaporine 1 in the ciliary body was inactivated, leading to the reduced eye pressure. Next, please. And then there are advances in protection of retinal ganglion cells by gene therapy. Gene delivery to the retinal ganglion cell is achieved by a single intravitreal injection through the corneal nimbus. The viral vector of choice is AAV. This small virus is non-pathogenic and confers safe and long-term expression of the transgene. The summary is given the recent laboratory studies utilizing gene therapy techniques to lower intraocular pressure and to provide neuroprotection and the continued development of tissue-specific vectors. It seems that we are well poised for a new generation of treatments for glaucoma. Next, please. And then we also have one thing more on the horizon: stem cell treatment for glaucoma. The development of stem cell therapies for glaucoma has been focused on the replacement of two types of cells for the trabecular meshwork and retinal ganglion cells. A recent study in an animal model glaucoma suggests that transplantation of stem cells to the trabecular meshwork lowers IOP through trabecular meshwork cell recovery and enhances the ocular outflow. Next, please. Once implanted, the stem cell derived retinal ganglion cells would need to migrate to the ganglion cell layer, partner with the appropriate neuroretinal cells, and trabecular meshwork cell therapy replacement may hold more immediate promise for translation to clinical use. It is exciting to imagine that trabecular meshwork cell replacement by patient-derived trabecular meshworks like cells may one day help physicians to treat patients with glaucoma. Next, please. Thank you very much for your patient listening.
Thank you, sir, for showing what is there in future for glaucoma management.
Yes.
We had very nice attendance and many congratulatory messages for all of you. You have presented very well, very nice presentations throughout. And I guess probably we have slightly overshot our time. So are we in a position to take questions, sir? Malla sir, Nadeem sir? Or we can...
Take a couple of questions, Rajesh, I think.
Next in 5-10 minutes, you can take the questions.
Okay.
And then we can conclude.
Yes, sir. So there's one question, does the changes in ganglion cell layer in pre-perimetric glaucoma indicate that central visual field changes also occur in pre-perimetric glaucoma? That is for Professor Bodla.
Thank you very much for the question. Actually, what I have been studying for was that the different studies I have gone through, that as far as the real field changes are concerned, their use is limited now. With the optical coherence tomography, we can pick up the changes earlier as compared to the real field, just like I was talking about the macular ganglion cell complex. So my experience has been that in way that if we take the macula only and if we do the real field in the case of the macular area and then we do the ganglion cell complex on the OCT, it is totally different. If we go on to the fovea up to the macular area, that is 8 plus minus degrees, while if we do the 6 degree, like 22 to 40 real field defects, it cannot be interpreted in the real field defects. So we can pick up the retinal for nerve fiber layer changes earlier as compared to the ganglion cell complex changes with the OCT. And as for, there have been a lot of studies and they clearly indicate there is a difference of 2 to 3 years time. By the time the real field changes, they become positive, but the changes in the retinal nerve fiber, they have been always there.
Sure. There's a question for Dr. Lalita, and the question is that in ocular hypertension without significant risk factors, at what level of IOP should we consider treating?
Yeah, ocular hypertension actually is the intraocular pressure more than 24 millimeter mercury in repeated reading. Consecutive readings, there's a persistently very high intraocular pressure, more than 24, I start treatment.
Okay. There's another question that can prostaglandin be used safely in young age group around 14 years for ocular hypertension?
Sorry?
Can prostaglandin be used safely in younger age group, that is around 14 years of age, for ocular hypertension?
Actually, it is not advisable because it causes a lot of pigmentation. And I am not practicing of prostaglandin analogs for younger patients because it has undesirable side effects on the eye.
Mm-hmm. Okay. There is another question, and that is, how important is measures of ocular pulse amplitude, given fact that a low OPA in low IOP is known to worsen fields rapidly, while a high OPA with high IOP seems to protect?
Sorry, I didn't get that.
The question is that how important is the measures of ocular pulse amplitude? How important is the role of ocular pulse amplitude?
That's actually, I have no idea about that. Ocular pulse amplitude means, sorry, I have no idea about that. Okay.
Okay. Then there's a question for Nadeem sir, and that is that in children, how do you evaluate effects?
Visual field effects.
Yes, sir.
Visual field effects can only be done in the the children who are capable of sitting on that machine and performing that test, who can understand that. And the children less than 10 years old may not be able to perform it. And secondly, we don't have a normative database for children in the visual field. And the machine will not be able to compare with the normative database or normal population. So you can do the test in younger children who are able to understand the test and play it like a game and keep on doing the test. And you can compare their own test with their previous test. Like you do the test today and then you repeat the same test of the same child 6 months later. And then you can compare the two tests instead of comparing it with the age-matched normal population. So similarly, OCT also hasn't got normative database for children, but you can do their test and compare their own test with the later tests so that you can see their progression in the visual field also in the OCT.
And there's one question regarding central corneal thickness in management of normal tension glaucoma. So any of you can take up this. What is the role of central corneal thickness in management of normal tension glaucoma?
Central corneal thickness is considered as a high risk factor. Particularly, it was established in the ocular hypertensive treatment trial. And for the normal tension glaucoma, if the corneal thickness is thin, then it becomes a significant bet. Maybe we have underestimated the intraocular pressure, and thinner corneal thickness is a risk factor for the progression of the glaucoma. That is true also for the primary open angle glaucoma.
Actually, it is really important in managing the normal tension glaucoma because corneal thickness has a low reading. Actually, they may have higher reading. Actual is a higher reading. Therefore, they have to have a very continuous, very close follow-up as well as very good treatment to control the intraocular pressure according to their progression.
Okay. There's one more question, and that is for Professor Meher, and they specifically want the emphasis of, what is the importance of OCT in management of glaucoma, whether we can initiate a treatment based on OCT findings, or OCT is just for, checking the progression and following up.
I didn't get your question.
Sir, the question is that whether OCT can be used to initiate glaucoma therapy.
The OCT, I showed to you that an early changes can be detected, and we also use it for the progression to certain extent. What we call as a floor level, when patient has got very advanced glaucomatous changes, then it has absolutely no value. Then we have to rely on the visual field examination.
I would like to add one thing to Professor Meher's answer. This is the difference between the structural changes and the functional changes. The structural changes, they always start first, and then they are proceeded by the functional changes. So there is a variety of cases. In early cases, you have to depend upon the OCT, but in the cases which are moderate advanced, then you have to do the visual field parallel with the OCT. That's what I think.
There is one question regarding calibration of tonometer. How often do you have to do calibration of tonometer for measuring intraocular pressure? Maybe Dr. Lalita can.
Yeah, actually, in the Goldman tonometer, you have to calibrate the tonometer actually in every 6 months. That's actually depends on the number of patients you are seeing. That also depends. And better to calibrate the tonometer. In my setup, I do them in every 6 months.
Can I
Yes.
comment on this?
Yeah.
I think the calibration should be done more frequently, and you'll be surprised that once you calibrate, in every meeting that we have in Pakistan, every time in a glaucoma talk, I ask the audience, how many of you calibrate your tonometer? because they are general ophthalmologists sitting there from the districts. And I assure you, you'll be surprised that out of 60 to 100 attendees, only 2 or 3 will raise their hands. And they said, we have never done that. And I calibrate because I also practice as a glaucoma specialist, but I do calibrate it every month. I make it sure a point to calibrate, but as the respected lady said, that every 6 months is a good practice, definitely. But if you want to be more careful, you should do every month if you're practicing glaucoma, definitely.
Okay.
Yeah. As a general ophthalmologist, we are seeing all the patients, and we do at 6 months, but I try to do more actually on advice. Okay.
There's another interesting question, and that is, how important is intracranial pressure vis-a-vis IOP in glaucoma?
Can I reply to that?
Sir.
I think now they are saying that glaucoma is not an ocular disease. If you see studies from Canada, they say that glaucoma is a neurological disease. It's not and the gradient between the CSF and the intraocular pressure is becoming more and more important. As I was preparing this presentation, so I saw a lot of studies focusing on the CSF pressure and changes in the intraocular pressure relating to that, but there was no time to discuss that. But definitely, there are a lot of studies being done on this, and there is definitely a relationship between the two.
We have many messages, appreciating the.
Rajesh, how many participants we had?
Sir, we had 12. We had 1,200 plus participants so far, as from whatever information I have received.
It's a good number. It's a good number.
Yeah, it's a very good number. It's a very good number, actually.
I'm sure it's going to increase in the next webinar.
Yeah, in YouTube, it will, even in YouTube, it will keep on increasing.
Yes.
But now we have these many numbers in Facebook, YouTube, and web combined. So, but YouTube, it keeps on increasing because people like to see it later.
We have one participant, Mr. Jogendra.
Yeah.
Not only that, publicity is also very important, as because that should be circulated to each and every country, so that every society member can attend. 1,200 for our country is limited, so there should be much more.
Yeah, that's very true, ma'am. Actually, but there are so many webinars going on, no? So that's why probably this thing is.
Are we live or are we done?
Yeah,
we are live. Is very important. Glaucoma.
So we have
this is very, very important.
Dr.
Rajesh.
Sir.
Yes, sir. Rajesh, are we concluding then?
Yes.
Yeah, we'll be concluding. We will have Ava ma'am's comment on how she felt.
I am really amazed, because all these 7 speakers, starting from Professor Shumon Thapa, Dr. Lalita, Dr. Moyuri, Professor Nadim Bhatt, and Dr. Shams Noman, Professor Maher, Professor Afjal Badla, and last but not the least, Professor Syed Imtiaz Ali, with so many scientific content and so many learning, teaching material. I myself have learned a lot, though glaucoma is very favorite subject from my very earlier life, as because glaucoma, it hurt me so much that it is not a curable disease, it is a preventable disease. And when when I have started my journey in the year 1981, after passing my fellowship part 1, from then onwards, I have seen a lot of different opinion about cataract and glaucoma. When they are in the bed of a ward side by side, and both are very much anxious for how will be the outcome of their surgery. Cataract surgery at that time, only intercapsular cataract extraction, but still patient can see. And about the glaucoma, if it is an advanced case, it's not possible to give back the vision back. So they are thinking that the surgery is not a successful one. And from then onwards till now, it has improved so much that today so many things about the macular ganglion cell, about the OCT, about the future newer drug, and also Dr. Moyuri, she has angle gonioscopy in such a way. I think most of if the resident or the young ophthalmologist or the glaucoma specialist, they are present in this session, they will be very much benefited, as because she is a very good teacher and she has teach us a very nice way from the normal to all the variety of abnormal. So I would not, if I want to explain everything, 7 speaker, then it will take a lot of time, and there are other panelists also. But I am not seeing Professor Shumon Thapa. His screening glaucoma is an excellent one, as because we know Nepal is a very mountainous place, hilly area, and the outreach screening is very difficult. But still, from 2011 to 2020, they have done so many studies in hospital based, also in Bhaktapur, one place there, and another is the out in different phase 1, phase 2, phase 3, with the smartphone, tele-ophthalmology, everything. But I have a question to him that what is the data? Did they have any data of blindness due to glaucoma? But I think Professor Tumoni is not here, but I will ask him later on. So, Professor Shumon, you are here. Will you please tell me what is the data of your glaucoma blindness in Nepal?
So we haven't been able to calculate exactly, because the population-based studies that we have done is just only for glaucoma, purely for glaucoma, is only in one of the districts. So Nepal being a very vast country with different terrains and different ethnic races, we haven't been able to, and extrapolating that data is not going to be accurate. But through and the RAP surveys that are being done, I feel that the RAP survey still underestimates the burden of glaucoma, because as you know, it's just a rapid assessment of blindness, and really we miss out on many patients who have visual field defects, etc. So unfortunately, we know that it is the second or third cause of blindness, varying from places to places. In fact, in a one population-based study that we have just finished up in the mountains, a study called the GRI study, we found that the blindness of cataract and glaucoma is equal in one specific ethnic race. So that is very alarming, and we are reporting that very soon. We have already submitted our paper to report that. So it is a major cause of blindness. The exact burden of glaucoma blindness we do not know, but however, hopefully we will be able to, even if we don't know the exact burden, we will be able to address it to some extent.
Okay, thank you so much. Thank you, Professor Okemala, Professor Rajvardhan Azad, Professor Nadim Bhatt, and Dr. Rajesh, the main hero of today, as because he has done a lot of things for this webinar. Professor Namrata Sharma, another very academic personality. I like her very much. Professor Imtiaz, Professor Badla, Professor Maher. I can remember everyone, their hospitality beyond any limit. When I was in Pakistan in SAARC Academy of Ophthalmology in 2016. So with all these, Mayuri and Dr. Sri Lanka, another
Lalita.
Dr. Lalita.
Lalita, right, right. So thank you so very much. I'm really, if it continues another hour together, I will sit and hear, as because it is very, very interesting and very, everybody, I think, like, and they will talk. Professor Namrata will say, of course. So
I
thank
really
you
appreciate, ma'am.
Thank you.
I really appreciate your energy level, ma'am, and I'm really thankful for your words of encouragement. And Dr. Namrata, as you said, that she is really academic, and both of us are cornea and refractive people. Dr. Namrata is, sitting and listening to all the talks very, nicely. I mean, that shows how much academic she is. How did you feel, Dr. Namrata, about it?
I think it was a wonderful webinar, and we've had some webinars in the past also in glaucoma, but this was absolutely complete. And the best part was that there was perspective from all the SAARC countries and from the entire region in the SAARC. So things were a little different, but then I think all of them just converged into one thing, and I think it was the scientific content was great.
For that, Nadeem sir has to be given the credit because he only designed the scientific content.
Thank you so much, Dr. Nadeem Bhatt, for doing
Rajesh.
Yeah.
Would you like to give some time to Nadeem? He organized this session.
Yes, sir. That's what I wanted to say.
And to Raj before I finally close this session.
He had to go somewhere. I messaged him, Professor
Ajay.
Yeah.
No, let Nadeem have something to say. He's the one who organized the session.
Absolutely.
So beautiful.
So
beautifully.
Scientific content has been his own.
Then I can conclude and close the session, isn't it,
sir.
Rajesh? I
Yes,
will take your permission also. You are the one who did everything,
No,
Please, Nadeem, would you like to say something, Nadeem?
Yes, sir. Yes, sir.
Please.
First of all, I would like to say thanks to the all the leading lights of SAARC region. We have, all the people which I can see on the screen. They are the leaders in their own regions, and they lead the spread of light in their countries, in their cities, in their hospitals. They are the ones, by the grace of Almighty Allah, bring light to the people who are blind or who are getting blindness or going towards blindness, especially glaucoma and cataract. So thanks and hats off all to you for being present here, sparing so much of your valuable time. We started at 5:30 and it's getting 9 o'clock in Pakistan. We planned for 2 hours and it has gone beyond 3 hours. So this is the beauty of this academic activity, that all of us are sitting here and our participants are also sticking to their screens and they are attending the whole webinar. And glaucoma is such a topic that you can continue for hours and hours and people will never go. It's such an interesting, and it's, all the time there is new thing coming up, new definitions are coming up, new inventions are coming up that people are always interested to learn. So my sincerest and heartfelt gratitude to all the leaders of the SAARC region and all the participants and all the speakers and panelists, especially Professor Azad, Madam Awa, Sharfuddin Saab from Bangladesh, and all my friends from Pakistan, OK Mullah sir, our chief, our boss in SAARC region. He's the boss now, he's our president, and we love him so much, we respect him so much. And this is the beauty of SAARC region, that we are so closely knit that, I personally, I never felt like going to American Academy, but I will always attend APAO and SAARC conferences because I feel that there is some connection with each other, and whosoever is there as participants or as organizers, they belong to the same area. They talk the same things, same subjects, same topics. Whenever you go to the West, you never find anybody of acquaintance or anybody who is having the same kind of thinking. So I never miss the SAR conference and the Asia Pacific, because there we get the energy and we meet each other and we like each other and we solve each other's problem. So with this, I would like to thank once again all of you for being with us today. Thank you.
Rajesh, do you have anything to say now, Rajesh?
Sir, I would just like to thank you all for making this webinar memorable, and definitely would like to thank our support staffs like Bageshwar and Sajid, and very important are the company IPCA, which has supported us for this webinar. And special thanks to Mr. Iftiar, who is very much there, and he managed whenever there was some technical issue, he managed to get the PPTs and shared the slides. So these things, for this, he is actively there. So I would like to thank them for
Thank you, sir. Thank you.
Successful. And of course, I would like to thank our seniors like you, sir, Malla sir, Nadeem sir, Ava ma'am, and all of you for making this webinar successful.
All of us are your seniors. So you will
Yes,
have a
ma'am. I would like to thank you also, because I get a lot of encouragement from Dr. Namrata for doing hard work. So thank you all.
Anyway, Rajesh,
leader.
Rajesh, you want to close it, or can I say a
Sir,
few
final words of wisdom from your side, sir.
No, not wisdom. Anyway, let me have some few minutes, to say how I felt about this webinar. Rajesh, you are the man of this webinar or day, but I must say that the presentations by each one of them has been of high standard. Though I am a retina man, but I learned enough glaucoma this evening, And special thanks to Nadeem, who organized this glaucoma session, At one time, we retinal surgeons must know about glaucoma also. At one time, I remember the other day, somebody was saying the glaucoma is the disease of the optic nerve. And I thought optic nerve is the ganglion cells. And we talked about ganglion cells. And the retinal surgeons should be equally involved in glaucoma session also, And some of the observation, comment I would like to make, the other day I was attending this, and the presentation was the normal intraocular pressure in this part of the world, at least in India, upper level is not 21, it is 18. And I want to hear from our colleagues of the region, do they agree to this kind of intraocular pressure? The intraocular pressure they are talking in the West is different from the intraocular pressure in this part of the world. I think this was a study done in RP Center, found that the normal intraocular pressure of the Indian population, maximum normal, we can say is 18. 20, 21 would be more than normal. Anyway, that's the observation, I wanted to share. And number two, in the anterior segment examination, it is imperative to not only examine the cornea, the angle, the AC depth, all that, the pupil is equally important. If you have substantial damage to the optic nerve, the RAPD, doing a good pupillary examination does give you help. One of the cases I was presented was the case of pituitary tumor, bitemporal hemianopia, where the optic nerve, probably if you had done pupillary examination, you can get a lot of information about the status of the optic nerve. After all, it is the optic nerve, which gets damaged, and you can do by just examining the pupillary reaction is what I was told that day, And number three is the three pressure. We talk about intraocular pressure only, but in glaucoma, it is intraocular pressure. It is the pulse pressure, which is dependent on the systemic blood pressure. And then lastly, the intracranial pressure, which was discussed in the end. All three pressures are equally important when you are talking about glaucoma. And another thing I couldn't understand is macular ganglion cell complex. I always thought, the part of the optic nerve which gets preserved till the end. That was what we were taught long time back. That's why one of the causes of tubular region, we used to say advanced glaucoma, where the macular fibers get preserved. They do not give way to range intraocular pressure so easily as the other parts of the optic nerve. I think this is something new to me, interesting though. And about the artificial intelligence I was talking about. Last time in the Asia Pacific, there was a session on artificial intelligence. I attended it because I thought it would be interesting. They are doing artificial intelligence in diabetic retinopathy. And I was told that, this is deep learning. I was told that in artificial lensing, if there is somewhere choroidal melanoma up there, and if you let the artificial engineer do it, the artificial engineer will just detect the diabetic retinopathy, will say if there is no diabetic retinopathy, it's normal fundus, whereas this patient has a little melanoma up there, So what we have taught to the artificial intelligence is what you will be delivered, the message, And I think it's not going to be easy for glaucoma to until now. I think they have done in diabetic retinopathy down there in the south, I believe. Anyway, I don't want to add more. I must thank each and every speakers. Hats off to them. I don't want to name them. They all did a wonderful job. I want to thank one and all for a wonderful webinar, the first one, and especially to Raj and Rajesh and Namrata, what a team, and Lalit, of course, I couldn't see Lalit participating much. I did see him, what a team from India, I was amazed in how popular these people are in India, when I attended one of those AIOS team, they all seem to, the whole world of ophthalmologists in India seem to know all of them, and it's nice to have them in SAO, South Academy of Ophthalmology. Thank you very much. Once again, I would like to say good night here. And unless Rajesh has something to add in the end, that's what I want to say. And that's all for me. Rajesh, over to you.
Just one thing I would like to add, sir. Special thanks to Professor Azad, who initiated this idea of having SAO webinar. And he deserves a special thanks for it.
Okay, fine.
On behalf of
us,
give him thanks, official thanks.
Yes.
I forgot Abha, Professor Dr. Abha. She is an inspiration too. Very academic. Quite a huge. She's so popular in Nepal, And we got a women in ophthalmology session. I did attend Abha when he was there. One of your
I remember
where your webinar session. I did attend. I'm glad that. To tell you, we have got 375 ophthalmologists, it's a newest figure. Out of that, about more than 50, 60, 70% are ladies. Thank you very much, I think credit goes to you also, Most of the doctors graduated from Bangladesh are ladies, and they are doing, each one of them are doing a wonderful job again. You will be glad to know. Most of them, I believe. Thank you very much. No, Rajesh, can you close this session now?
Sir.
Lee?
Sir, thank you, sir.
Good night. Today's youngest, one thing.
Forward to see all of you.
One thing, today's youngest speaker is Dr. Noman from Bangladesh.
Yes.
Oh, yes. Yeah.
Excellent presentation, Dr. Noman. Thank you.
Yeah. No, I already spoke to him in the beginning. He has been very academic, and he's there everywhere.
Thank you.
The WhatsApp, I hear you in
stop
WhatsApp.
the streaming now.
So many comments from Sam's.
Yes, thank you.
WhatsApp.
Thank you, madam.
Okay,
thank you, sir.
Okay,
thank you, madam.
so much.
Thank you.
Bye.